So, good morning, ladies and gentlemen, councillors. It is 10 o'clock on Monday, the 16th of October 2023. And this is the first in a series of meetings over the next couple of months to provide assurance and reassurance to our residents. So I hope that councillors will be able to join me as we prepare for a packed session of meetings between now and Christmas. In the end, this reflects the pressures on so many varied parts of the health and care system. So welcome to councillors and to our guests, both in presence as well as online. And apologies to anyone who is with us physically. I have the 50 pence out, but I can't find where the meter is, and I'm told it will warm up very shortly. Feel free to avail yourself of teas and coffees to keep warm. So this is Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. And I'd just like to start off by making a couple of introductory comments. The first relates to COVID boosters. And I would encourage, having seen a number of press reports that indicate the general public are not fully aware of who is eligible for COVID boosters, I would encourage members to share that information with your residents as much as possible. Those over 65, those who are physically vulnerable, and those in care homes are amongst the people, as well as frontline health and care workers, are amongst those people who are eligible to COVID vaccine boosters. So I'd encourage members just to share that information where possible. Second of all, Wallis Quarry, members will be dismayed to learn that the monitoring equipment for hydrogen sulfide, that's that nasty gas like a smell of rotten eggs, the monitoring equipment at now three monitoring stations at Wallis Quarry has been incorrectly calibrated since 2019. Work is going on at the moment to see if the historic data can be extrapolated or interpreted, and that work will be concluded by mid-November. Then it is up to us as a health committee to ask all of the relevant questions as to the health impacts from Wallis Quarry on residents, both the physical as well as mental health, and the impact on those who are healthy as well as those with limiting conditions or either end of the age spectrum. So in conjunction with your vice chairs, once the information was shared with us, we have agreed to put in an additional committee meeting to review the impacts and draw some health conclusions. This meeting, as before, will be held locally at the offices of Newcastle Borough Council and is scheduled for the 20th of November, when we should have the understanding of the impact on the health data. And please note, not only is it at Newcastle Borough Council's offices, but there's also a weird start time of 12:30, just to accommodate everyone's diaries. So let's move on to this morning's agenda. Can I remind committee that today's meeting is being recorded and is available for those who want to watch it back from the County Council's website. And it is also being beamed live for people to be able to be involved, and the recording equipment will cut off 20 seconds after the equipment has stopped. All voting committee members are in person, and there is a variety of people in attendance in person and virtually as our guests. I would ask our guests, as I always do, to accept that members have read and digested the papers provided, and as a result, could they restrict their comments to 5 or 10 minutes as an introduction to their item? And second of all, can we focus, committee, on the tangible outcomes for the residents of Staffordshire? And let's use the data and experiences that we have to sharpen the quality of debate and scrutiny. So on to today's agenda. First of all, apologies.
Good morning, Chairman. I've received apologies from Councillor Perry, Councillor Peters and Councillor Holton.
Noted, thank you. Anything else? No. Item 2, declarations of interest. So do we have any declarations of interest for this morning's meeting? County Councillor Anne Edgeler.
Good morning, everyone, and thank you, Chairman. Yes, I declare an interest as partner governor from the County Council on the Midland Partnership Foundation Trust.
Thank you, duly noted. David.
Thank you, Chair. I'm a physiotherapist, staff governor and armed forces lead at the University Hospitals Derby and Burton, and I'm a registrant of the Healthcare and Professions Council. Thank you.
Thank you, noted. And I should just declare that I'm a governor at the Further Education College, Newcastle and Stafford Colleges Group, NSCG, who is referred to in the packs, and no doubt we may talk about it in the end. So, can I just confirm for the minutes that we are quorate? I can see plenty of people, so thank you. So that moves us on to item number 3, the minutes of the last meeting, which was held on the 11th of September. There are a couple of amendments in the papers which I'd like to draw members' attention to. First of all, there is an amendment required under item 25. The second recommendation should be the Cabinet Member for Children and Young People. Second of all, I would like to pick up on page 3, the first actual bullet, the penultimate line. It says focused groups. I think that whilst they were focused, I think that we mean focus. So I'd like just to make that amendment. And then on the final bullet of page 3, which starts the agreed, and I think it should be the committee agreed. So with those 3 amendments, are we able to approve the minutes of the 11th of September as a true and accurate record? Thank you, appreciate that. And I'm reliably informed that all actions have been followed up, and members have not only a copy of the actions from each meeting on page 96 of the pack within the work programme, but there is also now a column to indicate where the action has been completed. So whilst we haven't rag-rated them because they're black and white, it is at least a way for members to be able to track that we have done what we said we would do. So item number 4 is the Staffordshire and Stoke-on-Trent ICS People Strategy. Just in terms of introduction to this, if we were to look at the 3 priorities, top priorities of this committee, one of them is about retention and recruitment, and about the people strategy. So this is an ongoing series of events that we have seen over a number of sessions, and this should be a follow-up to that. So without saying anything further, can I just pass over to Mish Irvine and to Gemma Trainer, who is online, who is leading us away. Mish, is that you? And obviously welcome to Alex as well.
Thank you. Thanks very much, Chair. And as we've said, that Gem is online. We also have Paul Draycott online supporting us from North Staffs Combined. We have Sophie Storr from UH&M, and we have Lorna Clarkson, who's going to be supporting us on the primary care slide. So Alex Brett, for those that haven't introduced yourselves to Alex at the start of the meeting, is the CPO for MPFT. I'm the acting CPO for the ICB, and we want to talk to you this morning and have a conversation really about our progress regarding our people strategy. We're here all together because we absolutely have a very collaborative approach to this. It's a distributed leadership model. We work really closely with each other and with our wider partners to try and find solutions for our workforce across the county. If we move to the next slide, please, Gem. So I won't be going through, as I said, we have had the papers, they've been read, but I will pick out a few points from each slide if that's okay. The context that we're working in at the moment is very challenging. We have an increased level of activity. Our current escalation rates are significant right now, so despite the fact that we're quite early on into the winter, it is really, really busy. We have got our recovery, so our elective recovery that we need to try and support. We've got a lot of complexity in terms of the cases that we're seeing, and we need to ensure that people are seen in the right settings and get the right care. Our workforce, there are a significant number of vacancies. Wellbeing is a huge priority for us, and I think that our colleagues will be talking about that throughout the session. Of course, you're all aware of industrial action and the pressure that that will have put both on the workforce that are involved, the workforce that are not involved but have to then pick up additional activity. And in order to do that, there will potentially have been some impact on service delivery. So industrial action has been a major challenge for us. Retention is something that we are trying to work really hard on, and we'll talk a lot about that this morning, because we will need to keep our workforce, the ones that we have that are skilled and that are specialised. We do have an ageing workforce, so we need to try and keep as many of those as we can. Finance is always a challenge for the NHS and for social care, to be fair. We do have a deficit as a system. We do have to think very carefully about how we utilise our resources, where we can find efficiencies, but at the same time, make sure that our staff are really well valued and that the patients and our citizens get what they need. So it's a challenging picture for us all at the moment. If we go to the next slide, it is very busy. But we wanted to bring to you some information to show really the progress that we've made over the last year, and I'm going to pick out a few pieces of information on that. So in terms of our turnover position, this time last year it was 1.7% more than it is now, so it's 10% now. That's very much in line with the national average, and to be fair, it's quite low in comparison to some systems. The overall target is to get between 8 and 9%, and we're massively on the way to doing that, so we're pleased with that. Our sickness rate is 5.2, and again, this time last year it was 1% more. And our vacancy rate is 12%, and last year it was 1.3% more than it is now. So we have still got a long way to go, but we are making progress, and we're hopeful that we'll be able to talk to you this morning about some of the initiatives that we have done and will continue to do to make progress on them. Next slide, please, Jem. So you've seen our annual report, which has talked about the progress that we've made over the last year. In terms of what we've done in the last 6 months, that lists our kind of main areas of achievement and the things that we're proud of. What we'd like to do is to show you, though, something that really brings to life all of the outreach, the widening participation work that we're doing, and how we're changing as a system the way that we approach recruitment and supply so that we can actually reach out to our community. So if it's okay, Chair, we'll show Asuda's story. This lady is a refugee that's been working and living in Staffordshire for a limited number of years, and she has come through 2 of our apprenticeship programmes, and hopefully will give you a real taste of what we're trying to do. I'll hand to Jem.
Hello, my name is Aisuda Zarqam and I'm a healthcare. I came from abroad as a refugee to study, and I found this apprenticeship, and I studied healthcare apprenticeship, which helped me to learn a lot about the culture, about the environment, and especially one of the things is because they sent me to different placement. I just learned a lot of things and see a lot of different people, and I had a chance to talk to a lot of people about the different things, and I think that was a plus for me. I love to help people. Is just that something with me as a kid. I feel like it's mostly with me. When I'm helping someone, it helps me, makes me happy. And I feel like, okay, I'd be useful at the end of this day. Like when I go to bed, I'm like, oh, I've done this. I helped someone. I make someone smile, and it's just put one pain away. That is all for me that I all need. Well, it was really nice. I enjoyed it a lot. Yeah, I have to work and study because I was able to talk to people and learn about the stories and what to do. And you don't think about the small things. As you look at the apprenticeship, you feel like, okay, I'm going to study. I'm going to go pass some exams and I learn some jobs and I'm going to fill some form and that's it. No, it helps you with going into social life and learn about lots of skills that's going to help you in the future in a life that you never think about. It's just a small thing that help you, and it's, at the end you feel like you have a family as well. This is always support you, and like you've done something, and I really loved and enjoyed it. Well, I finished my apprenticeship, my contract's finished. Now I'm working as a bank healthcare, and I applied for a pharmacy apprenticeship, and I was always love to know about medicines and how to use them to improve health, which I apply on that, and my course is gonna start in September, which I cannot wait for it. I'm gonna say go for it. Sometimes it's gonna look hard. It might gonna scare you about the job, but as soon as you go for it, like when you start, you feel like you know everything. It's just comes with a plan. It's just with a flow. You learn a lot. You get a lot of knowledge, and it's just amazing.
So thank you for the time to watch that. So just to kind of confirm and clarify for you, Isuda has joined our healthcare support worker system apprenticeship, and she's graduated from that. So that was a 2.5-year programme. And then following that, she's moved on to the pharmacy technician apprenticeship, which again, it's a system apprenticeship with placements in the NHS and also primary care in the independent sector in pharmacy. These are areas that we struggle to recruit, so there are kind of additional roles and responsibilities category within primary care. We are really struggling with pharmacy workforce, so actually we are helping her, but we are focusing our system-wide apprenticeships on the areas that we need our workforce. In terms of the future, so next slide please, Gemma. We've kind of distilled the long-term workforce plan, the NHS long-term workforce plan that I mentioned to you the last time I was here, and we've identified the really priority areas for us. We've also worked through the numbers that we will need to recruit to and to gain supply from in the next 15 years of each of our staff groups, so nurses, our AHPs, for example. I haven't brought that detail for you today, but that's the context in which we're working. So what we're trying to do is to be really clear about the priority actions that we do collectively to get us into that place. We can't do everything. And the areas that we're going to focus on in the 3 categories are train, retain, reform. We need to improve on our new to care. And just to pick that out, we're working in partnership with Staffordshire County Council on our New to Care Academy. We're funding it in partnership with them, and we'll be reaching out into the community to have more of our individuals, more of our population coming into care, whether it be at the start of their career or throughout their career when they decide to have a change. We need to stop robbing Peter to pay Paul, so these new to care workers, of course, won't be taken from existing care providers, and we can offer them the training opportunities as well as the support as they move through. We need to provide career pathways from care into health and vice versa. We need to be much more open about how we do things and much more flexible, so that's going to be a major part of it. Working really closely with our higher education institutions to support clinical placements, and make sure that we can actually, all these new trainees that are coming through, we can actually support them effectively to train and develop, which has been a big challenge for us, and we're investing in that as a system. In terms of retention, I've talked a bit about what we're doing, but the employee value proposition is the term that we're using. So why would you want to work for us? What can we offer you? How can we change our approach to be more flexible for we've got a multi-generational population that have different demands in terms of what they expect from us. So some of the younger people will want to have a number of different careers. They'll want to have a number of different jobs at the same time. Whereas some of the older ones like myself will need to be flexible. You know, I've got children and I want to be able to be there for them when I need when I need to. So we're being very proactive and very specific about the way that we're offering our flexible working opportunities and our other support mechanisms to help people stay in work. Using technology is part of that, so the digital staff passport and being able to work flexibly from home, for example, is something that we're trying to push out, not just for corporate staff, but also for clinicians when it's appropriate. Reform's a big area for us, so we absolutely are focused on reduction in agency work from a financial perspective, a quality of care perspective, and also an experiential one for the other people that are working with agency workforce. To do that, we need to have more workforce, and we need to be really clear about what we do collectively to reduce that. I've mentioned digital already. There's lots that we can do, and what we're doing from a particularly NHS perspective is considering how we can reform our people services so that we're much more efficient. I'm going to hand now to Gemma, who's going to talk to you a little bit about the summit which Jeremy attended, and we had colleagues from Health Watch there as well, so that was last week, I think, or the week before, and just in terms of some of the outcomes that we've had and then the next steps. Thank you, Gem.
Thanks, Mish, and morning committee. So this really quite bright, cheery slide here just shows in a nutshell our Aiming Higher and Higher Workforce Summit that we held on the 2nd of October. We had around 118 people join us from across the system. So that was NHS, social care providers, local authority partners, and as Mish said, we had a couple of members of this committee attending as well, which was fantastic. And then we had both clinical professional and workforce colleagues in the room as well. And what we posed was the kind of the big challenges that we're facing at the moment. So Mish kind of fed back to that group of people the same position that she's updated you on just now, and through that back to this really kind of mixed group of individuals from across the system to pose the question, how do we solve some of these really key issues? Just a couple of elements to pick out from the day's event, which was made up of key speakers from across the system, but external speakers as well, trying to sort of prompt thought and debate. And we had workshops as well in the morning and afternoon where people came together to think about some of those solutions. One thing that we asked them at the beginning was how well they feel we collaborate as a system on our workforce issues and those solutions. And really interestingly, we asked them to score between 1 and 5, and colleagues scored us 2, which would seem quite low actually. On first read, considering that we have been working together for some time. But we see that as a real positive. By the end of the day, colleagues had scored that a 3, but we were happy with that as a score in terms of the progress that we can continue to make with each other collectively to address those challenges. As Mish said, we view retention as a really big key ticket item for us at the moment and into the future. So retention was a big focus in that one of the workshops, flexible working in particular. We also talked about the culture and how we work together, and how we lead in a compassionate way. And we also looked at things like attraction. So how do we bring people in who are new to care from some of those external, hard to reach sort of areas? So a really productive day where we focused on the challenges, but really came together to think of some of those solutions. And then we have a follow-up on the 9th of November, face-to-face, hopefully, because this one had to be online with industrial action and with COVID cases on the rise. So we've got face-to-face with some of those operational clinical colleagues to really get into the detail on some of those topics and drive that forward. In terms of the next steps then from our long-term plan, as Mish said, we've started to get into the data, into the detail, into the information that we hold on workforce and some of the wider intelligence to help us really drill down and look at that plan over the next 5, 10, 15 years. We've been reviewing our existing priorities. We've been looking at the plans that are in place already and looking at the timescales in terms of what priorities we need to be delivering over the next year, over the next 5 years. We're really getting to grips with the feedback and the solutions that people put forward at our summit, and evaluating that whole event to A, feed the discussions on the 9th of November, but B, help to shape our future plans. And then all of that will come together as part of our really robust governance process through our People Collaborative and then through the People, Culture and Inclusion Committee, where we'll monitor our progress, we'll measure the outcomes and the value that each of our schemes are having on those workforce challenges. So I'll hand over to back to Mish and Alex.
Thank you, Chair. Hello, committee members as well. So I'm Alex Brett. I'm from MPFT. I'm Chief People Officer there. So similar to what Mish and Gemma have presented in terms of the system-wide programmes of work, of course, each organisation has got their own strategies and priorities to deliver, which are very much aligned to what Mish and Gemma have described. So what you've got in your pack is the breakdown and annual report from MPFT, which gives you an idea of some of the achievements over the last year. Obviously, this is a 5-year strategy under the 4 domains of the NHS People Plan. Excuse me. I won't go into these in too much detail, but just to say in terms of what Mish has described around some of the workforce trajectories, we are seeing improvements in a number of areas around our sickness and absence reducing, the lowest since April 21, vacancy rates reducing, tons of proactive work going on there to try and fill those vacancies, but also to retain our staff. We have got some pressure points, as many organisations have, so we're not immune to that. But hopefully what you can see from our report is a real focus on health and well-being and our staff experience, investment into attraction and retention, flexible working, reducing our sickness rates, leadership development and new ways of working, that innovation, thinking differently, and also in line with what's been described, growing for our future, our apprenticeships, volunteers, bringing T-levels into our work and also careers. I will leave it there, Chair, because I am conscious of time and moving on. So I think I'm handing over now to, I think it's UH&M. Thank you.
Nearly, Alex, it's me. Sorry. Hi, my name's Paul Draker. I'm the Chief People Officer at Combined Healthcare, and good morning, everyone, and thank you for inviting us. And really sorry I can't be there in person, but hopefully we just want to take you through some of the challenges and some of the achievements from Combined Healthcare's perspective over the last 12 months and where we are at the moment. So this is our people plan in a nutshell. Click, please, Gemma.
Paul, can I just make a suggestion? Could you just try and angle more into your microphone? It's just difficult to pick up what you're saying.
Okay, sorry, I'll come a little bit closer. Is that any better? Sorry, Chair. Is that any better?
To be honest, not much.
Oh, I'm not sure. Yeah, any better now? No.
We'll go with what you've got, but just try your hardest for us, please.
I'll speak up, which is not normally a problem, as colleagues will testify. So what we've got here is initially this is our people plan, and these are the outcomes that we're looking for over the next 5 years. And again, I won't go through those in details, but and we can share the details of the plan with members if that would be helpful. But what we've tried to do is outline in these 5 areas. Firstly, around inclusion and representativeness. I think we all recognise the importance of being representative of our communities and being inclusive, that sense of belonging. The evidence is very clear where people feel a sense of belonging within the workplace. That has massive benefits to them as members of staff, but it also has massive benefits to the people receiving the services that we provide. So that's our sort of big foundation that we build on. Great place to work, again, increasing the engagement, people feeling valued, really positive team cultures. Colleagues have already talked about health and wellbeing and the importance of that. providing opportunities for development. And I think, you know, one of the things that we do really well across Staffordshire and Stoke-on-Trent is that we work across organisations to look at career development opportunities and how we can make that work. And then the last thing was for our people plan is really around making sure we've got outstanding systems and processes that work for people, work for our staff, work for our organisations, work for the people using our services. Next clip, please, Gemma. Okay, sorry, that's gone a bit further than I thought. So can we go back one? Sorry, I thought we'd got a clip which is in the pack. Okay, it's not come. Oh, just go back one, Gemma. So just in terms of some of the things that are in the pack there, which have not, yeah, that's it. Perfect. Thank you. So we just in terms of the inclusion, these are some of the challenges, some of the things that we're doing in terms of we've got still challenges in terms of representation at all levels. We still have a situation where less than half the people from who are culturally diverse within our organisation across the whole get into senior management positions. So we clearly that's an issue that is still a challenge for us and challenge for all NHS organisations, and we're looking to address that with a lot of positive action across the organisation, including work on the race code and our workforce race equality standard. On that, we've also got a Black History Month celebration, as many have at the moment. And if colleagues and members would like, we have an open invite to people from the local authority and across the NHS to join us on the 30th for a Llewellyn Benjamin session, 2 till 3 on the 30th online, to see Baroness Benjamin speaking to us. So if you would like to be involved in that, please let us know. Great place to work. We have one of the top staff surveys in the NHS, and we'll see that in a second. Not being complacent, but that was, you know, is significant in the way that we try and work, that engagement of staff, that making it a great place to work, and that led one of the fundamental areas leading to us being named Trust of the Year, the HSJ Awards last year. Health and wellbeing we've talked about. We do lead the support hub across a system, and health and wellbeing is a massive focus for all of us. We know that there's still a challenge to come, that really the impact of COVID from a professional perspective is the peak of that is yet to hit us, and probably hit us over the next couple of years. There's opportunities for leadership development across the system again, and those are a lot of challenges, as a number of colleagues said, around vacancy levels. We've got 43 new nurses starting this month, which again will have a significant impact on our services. But we've also got the situation where, thankfully, we've got investment in mental health services across North Staffordshire and Stoke-on-Trent, which is leading to more vacancies, which is a good place to be in terms of that investment in services. And then next slide, Gemma, please.
Paul, it's really difficult to hear you, I'm sorry to say. Maybe we just need to think about whether we go through this slide in detail. We've seen the pack, we've read the pack, and we're under time pressure here, please. So maybe take a view in terms of the 2 points you want to make on this slide, and then the 2 points you want to make on the next slide, please, because we're not hearing most of what you're saying.
Okay, my apologies. This is my final slide, and it was really just to say you've seen it in the packet. It's just to outline the achievement around the staff survey last year, and that was it. Thank you, Chair.
Thank you, and that's helpful. And obviously, we saw your quality accounts earlier in the year as well. So thank you for that.
So thanks. We'll move now to UH&M and Sophie Storr, please.
Thank you, Mish, and good morning to the committee. I'm also here with my colleague, Kay Myers, on the call. Again, conscious just of time. So with the update from UH&M, we'll aim just to focus on a couple of key highlights. In terms of our people strategy for making UH&M a great place to work, within our plan for that, we look at it really under 4 domains, as you can see on the slide. So how we look after our people, how we create a sense of belonging, how we will grow and develop our workforce, and the way in which we'll develop our people practices and systems. So we are well on track in terms of our delivery plan for this particular year. And in terms of some highlights and key points from that, I was keen just to draw out. We have much of the bullet points on the bottom left-hand corner of this slide are work we do both at a local trust level and with colleagues at the system. So we have a very comprehensive wellbeing offer that we have regular initiatives. We have a number of ways that colleagues can call on support, both locally and at a system level, and some new initiatives that have come through on that too. And in terms of our winter planning, there are regular meetings in terms of that at system level and local level. And that includes what we're doing both in terms of bringing on board increased workforce and also in terms of our kind of bed capacity. We've done much to improve our employee benefits for this year and the support that offers, and equally making staff increasingly aware of those and how to access those. In particularly good news, our retention rates have been increasingly good. We're now at a point of our staff turnover at the end of September was at 8.3%. And again, our vacancy rates have continued to improve in the sense that we're under 10% in terms of the vacancies. Doesn't take away particularly some of the points Misha's made in terms of some of the particularly hard to recruit to posts, but we are putting in place initiatives through the trust and through the system in terms to tackle those. And some of that includes focus on new career pathways. We've also got, from a nursing assistant perspective, a new college programme that's launching in May next year, which has involved a lot of engagement with local colleges and sixth forms. So really just a raft of initiatives to improve onboarding new staff. From a culture perspective, a lot of work happening. One particular programme has been rolled out through sort of the summer months in terms of a Being Kind programme, a key focus for our organisational culture. Some of you may be familiar with the work of Tim Keogh. He was very much leading on that. And we've also had a variety of staff engagement, staff experience networks. We've got a new men's health programme, we've got a women's network, a variety of things from that perspective. We can't take away from the impact that the junior doctor consultant industrial action has had. I could only sort of reiterate what Misha said. You know, that's both in terms of naturally our focus on what that's meant for patients and relatives, but also the staff involved in that, plus impact on some of the kind of knock-on financial aspects of that too. But one of the last points on here, we're doing an awful lot of work to keep improving our retention, and one key element of that is the flexible working. So the trust, we recently completed a trust-wide survey in respect to this, and are very much looking at how better we can attract staff and retain them in terms of our offerings from flexible working. Having said that, probably would just like to conclude with that the National Staff Survey is underway now. And I know Paul obviously has made very good reference to that, but therefore our trust is very keen at the moment to enable our staff to be able to respond. So it's very much our response rate that is important to us, as well as the outputs and what those responses are when that time comes. So we are happy in the sense of where we are at, both at a local level and working as a system level, with the raft of things that are part of our people strategy at UH&M. Thank you, Mish.
Thank you. And then finally to Lorna for primary care.
Thanks, Mish, and I'll be really brief. Just I know we're up against time pressure, Chair. So just a couple of things that I wanted to highlight in terms of new ways of working to support primary care staffing and access to primary care. So at the bottom of the list, you'll see the flexible staffing pool, which is a central system for locum GPs to put themselves onto so that practices can reach into that to organise for them to work at their practices. It can also be used for the wider additional roles, pharmacists, physios and others that work within practices. The ambition is that these flexible staff pools will support groups of primary care networks at either an ICB or on a place footprint to increase capacity in general practice and create a new offer for local GPs wanting to work flexibly. So again, another offer and another potential to retain people who need that flexibility. And it also is expected to reduce the burden on practices and PCNs in terms of accessing temporary staff and to build up better relationships with the members of those pools. The other thing that you can see is that we're looking to increase the additional roles reimbursement scheme workforce. So that is the wider roles, and we are doing a number of things to increase that accessibility. We're running apprenticeship schemes. We've launched a general practice nursing schools scheme, which supports nurses to transition into general practice, which is often quite a different skill set. As well as a number of wellbeing initiatives to retain those ARS staff once we have recruited them. I think there's a lot to talk about, but I'll stop there just in the interest of time, Chair.
Thank you, and that concludes the presentation. Thank you, Jeremy.
Thank you. A lot of information across a lot of organisations to take in, so thank you for pulling all that together and sharing with us. I'm not seeing any indications early, so let me just use the chair's prerogative. We talked very quickly about sort of winter plan. One of the lessons from last winter was that flu hit early. So how winter prepared are we, and who wants to pick up that question? Mish.
So we have got for the first time a collaborative winter plan, and we're actually not calling it a winter plan anymore. We're calling it an escalation surge plan, because we're really conscious that winter can last, unfortunately, most of the year, and it's quite difficult to predict where we're going to get the spikes of activity. So we are very well prepared for the next 6 to 12 months. We're working collectively on that, and it's something that I have to say will really turn the dial in terms of that shared ownership and responsibility for it. We've got a workforce plan. We're very clear about where the gaps are. We're clear about how we are going to fill those gaps and what we'll do from a mutuality perspective of sharing our workforce as and when required. So I'd say, and I don't know if Tracy you want to come in, but actually we are very well prepared for winter this time.
Thanks, Mish. I think it's important also to recognise the vaccination programme. We've brought that forward as well, and it's really important. And I think, Chair, you mentioned at the beginning the importance of getting vaccinated. So that being brought forward. So the big spike that we got last December with the COVID and flu caused quite an early pressure on the NHS. So there's plenty of plans in place to work on surge and, of course, took the strategy and the learning from last year to bring forward the vaccination programme for people.
Thank you. Janice.
Thank you very much, Chair. Good morning, everyone. Just on that note, actually, I saw the surge plans, and it was good, actually, to see the numbers that have been quantified in this particular piece. If I could ask just I've got a couple of questions first, if I may, Chair, which sort of overarches, because there is a significant amount of detail here, which I think is really helpful. The bottom line is always, are we recruiting, retaining more happy staff? And I think that the details in the dashboard on page 51 shows us the direction of travel on that particular piece. My two questions on that element, because I think it's how we actually obtain that information about how the staff are, what's prompting them to leave in some cases. And we note the turnover rates, I think we've heard between 8 and 10% in different capacities on there. I'm sure that there's exit interviews that goes through with those, but if you could just give us some information about if there are main themes, and then that's what's led into some of your other initiatives that you mentioned at the beginning about flexible working and offers of that sort. And then the other question that I could do with some more information about is the appraisal rates, another mechanism where we find out about how the staff are performing, but also how they're feeling about it. And in some cases on page 51, we've had an increase, and in others we've had a decrease, and I think it might just be helpful to put a bit more detail to those, if you could, please.
So if it's okay, Jeremy, I'll address the first point and then invite colleagues to come in, and then I'll invite the CPOs to comment on the appraisal rates. Perfect. So in terms of the retention piece, we've done so much work on this. And as I said right at the start, it is because we have a workforce already that are trained, and we really don't want to lose them. The amount of time, money, and resources that's involved in recruiting another person is massively outstripped by actually doing something to retain them. So we've recruited a number of retention officers, and we've invested in that. I'm not sure whether it's happening elsewhere in our system. There's one aligned to each of the trusts and also into social care and into primary care. Those individuals go in and speak to the workforce and actually find out what it is that we could do differently. We also have, of course, the staff survey. We have the touch points that we do, so the kind of pulse staff survey stuff that they do throughout the year. The themes that we're seeing is primarily flexible working. It's not necessarily I want to work 3 days a week, but it's I want to be able to go and pick up my children on the days that I want to. I want to be at their plays. I want to be able to book my holidays in advance, because some clinical staff have really struggled to do that because they don't know they're off duty. So for us to be able to support them, and at UH&M they're doing a massive amount on this, to be able to self-roster. And it isn't just about self-rostering in terms of you can choose which of these rosters to take. It's actually inputting into that and creating rotors that support people. Yes, there's a lot of stress still, so COVID has had a significant impact on how willing and how tired people are to keep going. COVID has moved on, but the escalation bit and the elective rates of recovery and the amount of work associated with that hasn't. So yes, there's stress associated with that too, which is why we have the psychological wellbeing hub at system level. All staff are able to support to get support from that in social care and primary care as well. So it's primarily flexible working. It's primarily that kind of feeling of stress and wanting to just move away from this kind of hangover from COVID, the work that they've been doing. Now, I'll ask if any of my CPOs colleagues want to come in and add anything there. Do you want to, Alex?
Yeah, happy to add, and I think what Mish has described is very much the consistent themes that we're getting, I think, across most organisations, and I think all of us in turn. So we've got the system-wide programmes of work and the support, but actually that's only as we need to deep dive into certain areas. So one of the things we particularly do at MPFT, and I know other colleagues will be doing the same, is really highlighting where we know we've got those particular pressure points through our data. And we've got business partners that work in those areas that go in and support services to think about how they might do it differently. So there's a range of things that we will do to support those conversations, but also, as Mish has described, those key conversations at a local level around retaining people, finding different ways to support people in practice, but also to think about how that could be different in terms of their worlds of work. So huge amounts going on, but the themes are consistent.
Any of the colleagues online that would like to come in? If not, I'll move on to the appraisal rates. So you quite rightly picked out that we're increasing in our kind of agenda for change, so the non-medical workforce appraisal rates, but we have seen a dip in our medical and dental appraisal rates, and we are investigating that individually but also collectively. And on the long-term plan slide, you probably saw that medical and dental training, clinical education activity is something that we need to focus on, because we have primarily focused on the non-medical workforce. I don't know if Lorna or any of the CPO colleagues would like to come in and comment on the appraisal rates within their own organisations. I can see Alex is champing at the bit here, so I'll pass to you.
I'm happy to default to Lorna if she wants to come in first, but I'm also happy to no. I'll go for it then, Lorna. I think it's really challenging. Appraisal generally, I think, is quite challenging in that we want everybody to have a quality appraisal, and it's one of our key things that makes good people practice in our worlds of work. But I think in an environment where it's so challenging from a staffing perspective and really difficult, actually appraisal sometimes one of the things that does go. or is more difficult to achieve in the way we would like it. At MPFT, we're doing a real deep dive into how people are finding appraisal, how do we make it more meaningful, how do we make it easier for people, and what does that look like? So we're doing that work at the moment, but specifically related to medical and dental, that's one of the areas where we've got the highest vacancy rate. We've got significant challenges in some specialties, really difficult in terms of the staffing picture in some areas, and I think that sometimes hampers that ability to find the time to do appraisal. So, as Mish says, work to deep dive into what is really causing that, but also as thinking about job planning and making sure that people get appropriate supervision, and it's not all hanging on the appraisal, but in their day-to-day work, they're getting that regular sort of managerial and clinical supervision as well as the appraisal. And, you know, in our focus around some of the targets, trajectories, some of the staffing data, it's making sure that those development aspects and those things that we know are really meaningful to people in practice don't go. So we're all very much focused on some of those areas, as well as, you know, increasing staffing numbers, reducing sickness, all of those things, and they all hang together. So I hope that answers your question.
So I've got a couple of people online. Paul, do you want to come in?
I don't know whether you can hear me, but yeah, I mean, our appraisal, I agree with all that Alex and Mish have said. Our appraisal rates currently generally are just under 90% for the trust, and clinical supervision are just under 85% for the trust. But as Alex said, it's really important to get the quality and assess the quality, not just getting the numbers right, because it is such a vital part of ensuring that people are in the right place and understand where they're at and get those development plans. Because again, talking about the turnover, one of the big areas that we see is career development, and so making sure that appraisals linked to career development and people who've got those aspirations are given the opportunity to develop further, to make sure that those are in place.
Thank you. We're with you, Lorna.
Thank you, Chair. I think for us, certainly in primary care, it's the almost the exact opposite of what Alex described. So we know that our additional roles reimbursement staff are receiving clinical supervision as is right and proper to ensure the safety of the patients and their professional development. What we don't understand is how frequently those wellbeing conversations are being had, and making sure that those interactions within practices and within PCNs are thinking are along those appraisal lines, not simply in terms of clinical performance, but in terms of job satisfaction, personal well-being, professional development. And so one of the big pieces of work we're doing this year is really trying to get in and understand that and how we can improve those conversations, accepting that there's a huge amount of pressure on access in primary care, and every minute spent in an appraisal is a minute spent not seeing a patient, but it is absolutely a balance of those two things, because if we don't protect our staff and we don't keep them happy and striving for that continuing professional development, then we won't retain them. So that's a piece of work that we absolutely need to do to make sure that we are appraising those staff in a way that is supportive and is looking towards their development as well as the needs of the clinical service provision.
Thank you. Janice, we're with you.
Thank you, Chair, and thank you very much for all of those replies as well. It is one of those where it's a catch-22 because you're so busy doing the job, which I appreciate, but equally it's where we find those key nuggets of information, and more importantly, make sure that the staff that are doing it feel extremely valued in what they do. It's not just a process, it's what they are doing as part of their actual offer. There was another mention as well, just on that same mechanism role, about the surveys, staff surveys. And whilst we're having that dialogue, I just wondered if those are anonymised so that people are able to speak freely. One of the other items on the agenda later on, which I won't come on to more detail now, but just a quick question on that one. And then finally, Chair, if I may, you'll probably expect that I am really pleased that we can see the level of detail with regards to the educational establishment's involvement in here. And especially from the ages that we're working through, whether it's key stage 2, 3, 4 upwards. With the mention of apprentices, and I took advantage of using the links yesterday to have a look through that particular video that we've seen, are those across all ages? We have various apprenticeship schemes, and I think sometimes the mindset can be that they are designed for one level of age, where in fact actually they could be open to all, and I'm assuming all disciplines as well. Thank you, Chair. That was the last one from me.
Mish?
Thank you for those questions. In regards to the staff survey, easy answer, yes. It is anonymous. So absolutely people can say what they want to, and we take it really seriously. In relation to apprentices, so I'm so glad you asked the question. We have a 3-pillar Journey to Work programme. One is for the young people that are in schools and colleges and bringing them through. So when you're really, really young, understanding what health and care is, so people going into those schools. We've got an academy of volunteers from our workforce that actually go into primary schools and explain this is my job, and we've invested in equipment so that that's more experiential for them. As it gets older, then it starts to turn into the virtual work experience and then the physical work experience leading into apprenticeships. So yes, some of our apprentices are younger. We've then got the kind of middle level, which are individuals who are either new to care or want to have a career change. So our apprenticeships are absolutely open to everyone in the population, and a number of our apprentices are actually individuals that are, I suppose, older, depending on how you term that. We've just taken on 15 physicians associate apprentices, and all of those are actually individuals who have got life experience. So some of them are just university graduates, some of them, however, are kind of in their mid to late 30s and have worked in primary care or in health and care, and they've done a university career, and actually now they are going to become an apprentice physician associate. It's a higher level apprenticeship, but what we're doing is helping them to further develop their career. So absolutely the apprenticeships are open to a range of age groups, and I think some of the internal apprenticeships that the trusts will be able to talk about again offer people to be able to have worked perhaps as a healthcare for 10 years and then go on to do something different, a trainee nurse associate apprenticeship, for example. So we are trying really hard to make our opportunities accessible regardless of age. But also the third pillar is the seldom heard communities, and I've talked about that already regarding our outreach approach. So for us to change the way that we do things so that it's more accessible for people that aren't perhaps like us in the way that we would understand the world, so that we have to try and change the way we approach things rather than the other way around. Can I ask whether any colleagues would like to come in on that? I'll bring Kay in first, and then I'll come to you, Alex, if that's all right.
Thank you, Mish. I just wanted to confirm about the confidentiality part of the staff survey. UH&M have done a lot of work this year, Chair, on making sure that people realise that the staff survey is confidential. We have had some pushback in the past that people thought that we were tracking them, or that there was a way of joining their employee number with the answers. So we've had a big campaign on that, and we've actually seen that reflected in our figures, because we've hit 31% response rate this morning, which is actually took us 8 weeks to get to last year. So within 3 weeks, we've achieved that massive target. Just in terms of apprenticeships, I just wanted to say how seriously we were taking apprenticeships into our next planning year. So we're looking at apprenticeships as one of our main driver metrics for our People Directorate, which will mean it'll have scrutiny at all levels of the organisation through every committee. We'll use our service improvement methodology to make sure that we're hitting all of those 3 pillars that Mitch talked about. And just a real success story, I've got an apprentice in my own team who's in the 39 to 49 age bracket, who's actually decided mid-career to have a mid-career change in profession. So it's very much live, and it's very much working within the trusts, and we're putting a big focus on that into the new year.
Thank you, Alex.
Yeah, thank you very much. I guess in addition to what people have said, one of the things that we also do proactively, and I know other organisations do the same, is an in-year pulse check as well as the staff survey. Obviously the staff survey is yearly, it's annually. and by the time it comes round again, obviously a lot of time has passed. So for most of us, we are doing pulse checks in year to make sure that we know how people are feeling throughout the year, not just at one point in time. And absolutely, as Kay's described, loads of work around the anonymity of that, which does increase response rates. The final thing just to say in terms of apprenticeships, obviously the long-term workforce plan for the NHS that's recently been published, one of the key drivers in terms of our future workforce is around apprenticeships. So huge expansion, I think, that we're expecting. And one of the things that we all do really proactively, as well as people either changing career or those entry-level roles, is use apprenticeships for our existing workforce in terms of their development. So we are maximising the apprenticeship levy right up to master's level for our existing workforce as well, so that we can really think about our existing workforce and their development plans, as well as those entry-level posts and people who want to change direction. Thank you.
Thank you, Janice. Charlotte.
Just a couple of questions. You continue with international recruitment, although you're pledged to reduce your international recruitment. Can you tell me what roles you're recruiting internationally, where from, and in what numbers?
Thank you for that question. What I'm going to do is actually, because we do have our CPO colleagues here, is to ask if they would like to come in first. I'm happy to cover it, but if colleagues would like to come in on that. To be fair, the majority of the international recruitment is within UH&M. Kay, did you want to come in, or shall I cover this one off?
I don't have the data right in front of me at the moment, Mish, so I'd be willing to further carry on with what you say, but if you could answer the data part, that'd be amazing.
So, yeah, we have recruited 100 Indian nurses into UH&M per year for the last 2 years. In terms of the plans for this year, I would have to defer to the chief nurse at UH&M, so I can get that information for you, not from you. They are from India, so in terms of where are we recruiting them from, and that is happening at UH&M at the Royal Stoke site, but also for the Stafford site, and there is a significant pastoral care support offer for those colleagues coming in, so that we don't see the attrition and we welcome them into the community.
Because obviously the concern is that we can't rely on other countries to train our staff, denuding their health system of much needed staff.
Yes.
So I would like to see those figures. Another issue, which is mentioned in passing within the document, is about action on violence towards violence and abuse towards staff. So what are you doing to deal with that issue, which inevitably has an impact on retention of your staff if they are subjected to violence and abuse in whatever setting that might be? So if you could let me know what you're doing. I mean, I imagine that probably A&E has the worst abuse, but of course there is quite a lot of abuse just on wards. So I'd like to know what your programme is to deal with that particularly nasty situation.
Thank you. And we have taken that up so seriously in terms of that. So we're very clear as an organisation and as a system that we will not tolerate abuse towards our staff. We've just signed up as well to the Sexual Safety Charter. And as an organisation, as a system, we do stand together with our workforce on it. Now, we hear about it through the staff survey as well, so it is possible to identify not individuals, but if there are any areas where colleagues are seeing and feeling, especially, for example, in A&E, you might find that there would be more of that. And then there are deep dives done into exactly the specific incidences and also what we can do to support staff and have group conversations with our workforce where we need to. Can I ask whether any of the CPO colleagues would like to come in on this particular one? Okay.
Thank you, Mish. Yes, just to reiterate, we are doing a lot of work in the background, looking at what zero tolerance actually means to us and outlining that in more detail. We've got a full robust action plan around sexual safety, and we're working in the background to look at all the touch points to make sure that if any violence or any sexual safety concerns are raised, that we've got the full training for anybody who may hear those concerns, but also that we've got robust pathways in the background to make sure that nobody slips through the net. We're taking it seriously, and our Chief People Officer is chairing a 2-weekly sexual safety and violence meeting, which actually starts this Thursday, and that will monitor the action plan and report the action plan into our exec colleagues through the exec meeting.
What action do you take against people who are perpetrating that violence? Is it just internal security, or do you go to the police? Because it seems to me that unless you make it clear, not just by robust, programs or standing by your staff, but actually taking action against the people who are very often getting away with this abuse and violence.
Kay, do you want to come in?
Thank you, Chair. Just to reassure, we're working with our safeguarding colleagues to look at what those thresholds and levels are. We're working with that in terms of when an individual who's the victim of the violence wants to be in contact with the police. We support that as an organisation, but we're also looking at what thresholds we would take as an organisation in relation to that incident of violence as well. We are in the early stages of reviewing this work, and I'm sure we'll be able to give more detail as we move forward.
Paul, do you want to add something from your side?
Yeah, thanks, Chair. Yeah, just from a mental health perspective, clearly, there are times where people are admitted and they're admitted that they're most unwell in terms of their mental health, and there are a number of instances of violence and aggression exhibited on our wards particularly. And like all the colleagues, we've got a real focus on this, and I think I said that in the slides. I think the bigger area for us, which is probably different to physical health services, is around least restrictive practice, trying to look at practices that enable and encourage and engage with people in our services rather than trying to restrict. And I think the evidence is very good around where you have least restrictive practice, you get less violence and abuse towards staff. So there's a big amount of work there. But there are times clearly where people, even though they're in a mental health institution, that it's not their mental health that is causing the violence to occur. That it is, other behaviours. And at those points, we do prosecute. Not very often, but we will prosecute individuals if that's the case. If they're targeting staff and it's not related to their mental ill health.
Thank you. Charlotte?
I saw a lot of detail in your paper, but I didn't see any figures on whether violence and abuse is increasing or decreasing over the last couple of years. Were the figures in the document, or are they elsewhere?
Sorry, yes, that they are elsewhere. In terms of the work, so in terms of the staff survey, because the staff survey has just gone out, we didn't report the staff survey from this year, but we can come back and do that when we have the results in. In terms of the number of incidents that have happened, and because of course there's root cause analysis when there's an incident, and we will take action based on what the outcome of that is, we haven't included that. It's seen as, I suppose, more of a within the governance and the quality and safety areas rather than the workforce. So we didn't include it, but I can get that information for you, Charlotte, if you would like it.
I think it's a little bit worrying that the figures are not recorded. It gives the impression, obviously the wrong impression, that perhaps they're not taken as seriously as they should be.
Sorry, just to clarify, the figures are recorded, but we haven't reported them today as part of the papers that you've received. So just sorry to clarify that. Alex, did you want to come in?
No, just to, I guess, concur with you really. So they are reported and fairly robustly internally. So they would go, as Mish has said, through our quality and safety route and are reported as incidents. We what we've reported today is obviously our workforce picture, but there are very robust mechanisms internally in organisations to monitor violence and aggression incidents, to think about the training that staff receive. So all that's monitored through our quality and safety committees. The other thing, as Mish says, is that there are questions within the staff survey, so we can monitor those trajectories in terms of staff experience and what staff believe are happening. So there are two questions. One is around things that they've witnessed by colleagues, but the other one is by patients, carers or the public. So there are two questions in there, but it is very robustly monitored internally in organisations and taken extremely seriously.
Thank you. I've got 5 other speakers, or questioners, so I'd like just to move on, but accepting that we'll get a written response on both of the issues that Charlotte raised. Baz, was this in relation to this subject specifically?
Yes, it was, Chair. It's just to bring up this issue and not take away the fact that staff don't have, excuse me, get violence towards them on wards and stuff like that. And as mentioned, mental health can make that a lot more complex. It's just to say some of the work that we've been doing and the feedback we've been getting from patients is those with autism or learning disabilities, and sometimes how the zero tolerance is applied to them when it takes them a lot longer to explain what their issues are and not to be excluded from those services. So that is some of the feedback that we are getting, and we have been supporting and with the colleagues here with the health passports, so it helps colleagues to understand within services how they need to support people with autism and learning disabilities. It's just not to take that away, to recognise there's a lot more complexities involved here.
Thank you, really useful. David?
Thank you, Chair. Firstly, I just want to say how great it is to see a slide for the allied health professions, and I want to thank everyone and wish all the allied health professions that work in our systems a happy HP Day, which is on Saturday. So a bit more positive. But I do want to say that just to go back to Charlotte's point and his answer, for me as a healthcare professional, zero tolerance is zero tolerance, and no healthcare professional who's caring for our sick and vulnerable people should, suffer from violence trying to do their job, and I'm sure we all agree with that. Anyway, on to my question. Throughout the document, sort of leadership development, new ways of working and innovation, they're all sort of discussed at quite a high level, and I just was wondering if you can give the committee any more details or any more specifics around that. Healthcare is basically a people business, and so I really appreciate what you're doing, but I just want some more details around leadership, next ways of working, innovation. Thank you.
Thank you. So we have got the experts in the room regarding the leadership development, so I'm going to bring Paul in to lead on that. Just from a summary perspective, there are a number of leadership development programmes that are in place for our managers. And I suppose what we're trying to do as well is be very inclusive in the way that we do things. So we've got some leadership programmes specifically for those who are from seldom heard communities as well. We've got a high potential scheme that's in place to support the development of our future senior leaders. Each of the organisations have got their own as well leadership development programmes and kind of career pathways within their trusts. So I'll bring Paul in initially, but I'm sure then other colleagues will want to give you some detail because there's a lot of it.
Yeah, thanks, Mish. And yeah, great question and absolutely spot on. I mean, leadership is absolutely crucial in this area. And I mean, Mish sort of stole my thunder, really. We've got a number of programmes that work across the system, and we've got a number of programmes that work within organisations. And funnily enough, we've just finished a mapping exercise to actually map all of those programmes, and they cover the range from sort of first line management and leadership, your first supervisory management job, right up to sort of executive management and leadership roles and everything in between. And as Mish says, I think one of the great successes within the system is the high potential scheme, which looks and takes people who have that sort of potential to be our future senior leaders, whatever part of the organisation, and really develops them, really invests in those right through, as I say, to those frontline and first line leaders. I mean, it might be helpful if we share, if you're interested in more of the detail, because we could go into all the detail right now, but it'll take us forever. We can share that sort of the headlines of that mapping exercise and show the length and breadth of the detail of the leadership programs, management programs that we've got running within our organisations, if that would be helpful.
Thank you, Paul. Are there any of our other CPO or Deputy CPO colleagues that would like to come in? Kay.
Thank you, Mish. I just wanted to talk a little bit about some of our offerings. So we've just had over 3,000 of our colleagues who've attended our Being Kind training. So although it's not necessarily badged as a leadership offering, it's about leading in a kind way within the NHS and within UH&M. So talks about the feedback mechanisms we can use as leaders and as colleagues. It talks about how to receive that feedback and looks at the principles of being kind, compassion and civility. So that's really important, and thinking about that going forward, we've moved from face-to-face now to e-learning delivery to make sure that everybody has access to that course. We do have Enable, which is our leadership training, which is part of our Essential to Role training for anybody who's in any type of management role. So it looks at the fundamentals of management, but it takes that further to look at the principles of leadership as well, and then matches into the system-wide offerings that Paul's just mentioned, taking that further, looking at the people promise, our values, and linking that into how we make UH&M a great place to be treated and work. On top of that, we've got our specific leadership programs that come at a silver, gold and platinum level. So we use these as part of our talent management strategy to actually support our leaders with potential or our leaders of the future to develop the skills that they need. So it's a modular program and it covers all your traditional leadership roles, but it takes that further using some action learning and some real tools in terms of embedding that with a 6-month and a 12-month check-in. We're also looking really closely at the moment at our talent and succession. So we talked earlier about retention and we talked about how we support our staff. We're looking at a pilot with our very top leaders and moving them through the organisation in terms of making sure that everybody's supported with a talent pathway or a career conversation, and that will be used then to make sure that our leaders of the future have got the right skills. More than happy to chat through any of that with anybody or send any more information if anybody wants that.
Thank you. David.
Yeah, thank you, everyone. It's just, is there any output some of these leadership programs has, which we briefly talked about sort of equality and diversity of our boards. Has there been any change in there from these leadership programs? Is there any case studies? Is there any metrics around retention that these leadership programs have sort of directly delivered? Because I think we're great at putting these on, and it's great that we've got a really comprehensive suite of different opportunities. But I'm just thinking about how do we connect that up to really delivering for our staff. Thank you.
Paul, you're indicating, or?
Yeah, I think a lot of it links back to the staff survey, doesn't it? I mean, because as you say, you quite rightly say, it's, some of it is not directly. You can't say, well, put this leadership program on, and therefore we've improved this aspect of our performance. But I think there's a lot within the staff survey, and we've tried to look at outcomes within our people plan that demonstrate how our inputs are going to make a difference. And so if we look at our staff survey results within combined, so if we look at things like staff engagement, how we work as a team, having a voice that counts, all those aspects are directly linked to leadership. So we've tried to link those questions within the staff survey and those areas within the staff survey to our leadership development, to look at making sure it's having an impact. And for us, clearly, we've got one of the best staff surveys in the country, and those areas, that staff engagement, from a mental health comparison with other mental health trusts, then we are the top in the country. So it is making a positive impact for us, and that's on I think last year 69% response rate to our staff survey. So not all of our staff, but certainly nearly 70% of our staff responding to that. So we are confident, but we're not complacent. We've got to do more, because 30% didn't respond, and we've still got people that aren't having an experience that we want them to have within our organisation. So it's an ongoing challenge to make sure that we continue to improve.
Thank you. That's really useful. And Kay.
Thank you, Chair. In terms of measuring the impact, what I could give you at the moment probably is a wide range of qualitative staff stories that actually show the difference that our leadership interventions have made to individual lives, individual career progressions. What we do recognise at the moment is that we don't always evaluate as well as we could do, and we've taken to our committee our figures around things like our BAME rate at our higher levels to actually start using that data as part of the scrutiny. So we're at the stage at the moment where we're looking at that data and we're setting some more of how can we tell that these leadership interventions are making a difference, as you've just said. So we will work then to triangulate that data and look at the actual overall input. What we do know is that from our cultural dashboard, our overall engagement score is on an upward trajectory. And although we can't say that's directly attributable to the work that we're doing on leadership, we know that actually leadership and management have a massive impact on engagement. So that will be one of the key indicators of that, along with the Being Kind training. So at the moment, we've got the qualitative data, but I think we've got more work to do in terms of how we use the quantitative data. We have seen an increase in our management level at Band 7 and Band 8A in terms of ethnic diversity, and we're now looking at how we can use our talent programmes to make sure that that continues through our other levels.
Thank you. That was a very comprehensive answer. I think Paul offered to provide a mapping of the learning and development programmes. That would be useful to see as the written response. And I think there was a general conversation there about adding in some metrics to your KPI pack. So maybe next time we see the KPIs on employees, there's something either about that L&D pathway or alternatively about employee engagement, which I think is what Kay was signalling. Anne Edgeler.
Thank you very much, Chairman. Yes, I welcome the work that you're doing in the schools. I think it's absolutely brilliant, you know. And growing for the future, on page 10, you mention about launch of virtual work experience programmes, mental health, primary care and social care. When will this start, please? And the other question is, on the delivered side on page 10, outreach advisors have completed targeted engagement work with various community groups, Amenity Hub and Sanctus. Where are these based, please? Thank you.
I'm assuming
I
that
missed it as well.
I'm assuming that you are talking, Anne, about the annual report, is because we're all on
I'm
different
talking
page
about
numbers.
Page 10, growing for the future.
Okay, so page 10 is blank in my pack. So
there's a whole report before this report.
what is the... Sorry, I just want to make sure we're on the right page. So what does it look like, please?
It's just lists.
Just lists.
I think it's page
10 of the annual report.
25 on the PDF.
Yeah. Annual report, yeah.
Brilliant. I'm really sorry I missed the second part of your question. We can answer the first one, no problem, but I missed the second part.
It was the Amenity Hub and Sanctus. Where are they based?
Oh, right, okay. So what I'm going to do for both of these is to bring in my colleague Gemma, although I would love to wax lyrical about virtual work experience. It's something that I don't think I should be able to take credit for because her team have led it and it's well embedded now. It's been launched a year ago. So I'll let Gemma talk to you about it.
Thank you, and thanks, Anne, for your question. It's something I remember last time we came to the committee that you were really passionate about the school's work that we're doing, so that continues. Regarding the virtual work experience, as Mish says, it's been running for quite some time now, and we've launched, and we're in the phase where we're rerunning those programmes. So we've just started a rerun of the mental health programme, and we're working with the provider Spring Pod to come up with a more sustainable, longer term option for that virtual work experience programme, and continue to work with the providers. An unashamed sort of plug for that programme is that we were shortlisted as a system for the HSJ Digital Awards, and we got highly commended again as a system. So this wasn't just the work of our team, this was the work of the system colleagues in inputting into that. So that was the virtual work experience. And then regarding the Amity Hub and Sanctus, they are the organisations that we work with from a refugee and asylum seeker perspective, and that's the outreach work. So they're based in Newcastle and within Staffordshire and Stoke. So hopefully that answers that question.
Thank you very much, Chair.
Anything further? Richard.
Thank you, Chairman. On the last part of the report, in terms of GP networks and so forth, I was quite interested in what's been implemented in terms of how you're going to progress. I think it's helpful at some point, I don't know exactly when, but if, for example, launch of general practice staff survey, I know this has been already alluded to, but I think to understand what you've done and the outcomes from it, it is about, you know, in terms of participation in that survey, what level of participation, because I can't see that it's there, that can give you a proper direction, because there's always, with staff surveys, there's always a level of cynicism that comes involved with them. Well, what's the point? Nobody's going to take any different note, etc., etc. So it really is capitulating the importance of a survey that actually can demonstrate from it that actually you are looking at innovative ways of doing things, etc., that are meaningful and actually do change things to the benefit of others. Is that something that can be expanded upon at some point? Not necessarily at this meeting, but I do think it might be some valuable information that would help us to understand. You know, we are scrutinising, and it helps us to analyse. Thank you.
Mish, we're with you.
Thank you. Really good points. You know, I think in terms of general practice, it is very difficult for us to, sometimes get engagement, because there will be a variation in terms of those individuals about whether they wish to engage with us as a wider system. Each individual has their own priorities and their own challenges based on their local population. So for us, when gathering workforce data of any kind, it's been really challenging within general practice. What we have done, as I mentioned earlier on in the meeting, is we do have a retention coordinator that works specifically with primary care. Her name's Michelle Harris, and she's working with GPs on the staff survey. So how can we, A, develop those questions in partnership with our wider colleagues, but B, how can we get the best uptake of it? We've got a workforce implementation group for primary care. This has GPs, it has higher education institution colleagues, it has my team, it has a number of different colleagues on there, and this is where those conversations are being had. So before we implement something, we will consider all the different perspectives about what is, you know, basically what's the best outcome that we can achieve realistically, and what best then to prioritise on. So yes, it is something that will be challenging, and I think probably an iterative process over the next few years in terms of what the outcomes have been. I believe that general practice is coming to this committee over the next few months. Is that correct? So I can liaise then with Tracy Cox, who leads on general practice, to see whether she can talk to you in a bit more detail about this at that meeting, if that would be acceptable.
Richard? Okay, thank you. Yeah, I think we would welcome that, is the answer to the question.
Great, thank you.
Yeah, I'll look for the data in a minute. Jill Hood.
Thank you, Chairman. It was really in relation to the question that was asked by Charlotte. I noted on page 56, this ties in, that you wrote that your retention rates were less than 9% and your vacancy rates below 10%. That doesn't mean anything to me in a percentage. I would appreciate if you could actually put the numbers of retention and the numbers of vacancy. And I was going to ask, in reply to Charlotte's question, that you also don't translate that into a percentage. I'm sure it would be helpful to other people as well, just to put it into perspective, because I don't know 10% of what.
Thank you, Chairman.
Mish.
So really happy to do that. The figures that you're referring to are the UH&M figures around that's specifically for them, but we're really happy to tell you the number and then the proportion of the whole, because I can understand that would be helpful, and the same for the Charlotte query as well, so I can get that to you.
So will you give us those numbers by just like a written response?
Yeah, absolutely. We have it. We tend to summarise by percentage, thinking it's helpful. So we can do.
It's just useful to bring them back, and then at least those members who have got an interest in specific areas can pick that up.
Yep, no problem.
Anything further? Okay. I'll just make one other point, which is I know sometimes when we do quality account reviews that there can be a lot of them at short notice around sort of May time, but a lot of this information is available through there, and it's worth tracking, you know, some of the responses, particularly staff surveys and some of that engagement stuff. So I would encourage members to invest the time, because it is well worthwhile. John.
Yeah, thank you, Chair. Can I just say, Mish, to you and your team, I thank you for an excellent presentation this morning. Although I have to say, and I didn't think I got a problem with hearing, but a lot of the audio went, so I couldn't hear it. I just wanted to ask, just make a point, really, in a rhetorical question about recruitment and retention. And you've said about flexible working is important and all this, and all the work you've done on wellbeing. But, and forgive me if it was mentioned in the report, but my computer's died and I couldn't read what was up there. I'm in a bit of a state, really. But what about salaries? I mean, was there any feedback requested on salary satisfaction? Because it seems to me, particularly given with the strikes that we've had recently in the NHS at all levels, particularly with clinicians, was there any feedback on that? Because the elephant in the room to me is salaries, because it's abysmal. The remuneration, and until this government gets a grip and starts to listen and pay the staff what they work. I mean, why would you? Why would you spend 12 hours in a life and death situation when you can earn more money scanning sausages in Aldi? So, as I say, I'm not expecting an answer in this public arena from you what your thoughts are. I just wondered if that was a question on the survey and what the feedback was. Thank you, Chair.
So just in terms of audio, we'll pick up your point, and we are trying to encourage our guests to be in person. I know Paul would have been this morning, but for personal reasons, so I accept that, and we'll pick that up separately. 29th of January for primary care, and we're with you, Mish.
Thank you. And Alex has indicated that she'd like to comment, but I think that you are right. I think that this is a really significant issue for us, and I think we can all see from the news that we've had some very unhappy staff for a number of years, really. What we're trying to do, the point you made about Aldi, of course, primarily links to our non-registered workforce. So that employee value proposition bit around the flexibility, around the career pathway, seeing that coming into our care workforce is going to give them something in the future, not just, so that they might be able to compare with Aldi and say, well, actually they pay £10 an hour and I'll get the same over here. But what they won't get in Aldi is that career pathway potentially, and the bit about actually caring for people. So what we're trying to change that kind of, I suppose, the public's perception of that via the New to Care Academy. And I acknowledge, though, it's a major issue. In terms of the staff survey and the queries on salary, I'll bring Alex in, if that's okay.
Yeah, thank you. Thank you. Thanks for the question. There's no doubt about it. It's highly emotive, very difficult at the moment, and it is very live for us, I think, in terms of the issue around pay. So we're living and breathing that as we speak. We do, I think, in the run-up to some of this, we have seen that coming through some of our free text comments in our staff survey. So it is something that's there and present and live. But of course, as NHS organisations, we're bound by national terms and conditions and the rates that are set by government and NHS England. So we have very little flexibility within that. We're bound by our national pay framework, so it is a live issue for us. But I have to say, when we look at our retention data, it's not always the main reason why people leave. And often there are a multitude of, as we've talked about earlier, a multitude of other reasons why people might choose to leave, and that's very much around work-life balance, around flexibility, and some of the things that we've talked about today. Pay is often not the biggest issue why people will leave and move on, but what it is a big issue in all of the, I guess, media and press coverage around the current state of play is it does affect our ability to attract. Very much so. So, yes, a very live and real issue and very present for us. And I know Paul wants to come in and comment further as well. Thank you.
Yeah, thank you. There is a question in the staff survey specifically on levels of pay, and the satisfaction on that has gone from 48.5% to 36% in combined over the last year. So, yeah, it definitely has an impact, and it's definitely a deteriorating position. Overall, nationally, satisfaction with levels of pay is at 29%. So you can see that there's not a great deal of satisfaction with levels of pay within the NHS at the moment.
If I may, Chair, yeah, I wasn't accusing you, or I understand it's a central government issue. I really do. And as an ex-clinician myself, I know most of the people that work in the NHS don't do it. That's not their driver. It's the satisfaction. But you can only get by so long on it's a calling, it's a vocation. And whatever anybody says about why they do it, you do it ultimately to put bread on the table. And I think it is a real issue. And I think staff are vastly underpaid. And as I say, I'm not saying it's not your fault. Obviously, it must frustrate the bejesus out of you. But honestly, when you try and do all this other good stuff to attract people in...
Is there a follow-on question? Sorry, Is there a follow-on question to what you've heard from the relevant people?
I was just qualifying what I'd said, Chair. Okay. I will shut up now. I'm conscious.
No. I was just trying to sort of follow the line you were going to go down. And
no, I wasn't going to drone on for much longer, Chair. Thank you very much.
Okay, thank you, John. And it's an important point that's made. And interestingly, Paul, that stat of 1 in 3 only satisfied with levels of pay, I think, is a really useful point to underline that. Keith.
Yeah, sorry, Chair, not to elongate things even further, but mine are just more observations more than anything else. And I do think the report overall seems to be written more or less for an internal perspective. It's you looking at your own staff. Whether it's been written for us to scrutinise, I think, is another whole question, because I think there's a whole load of details here which we don't understand. There's list after list after list in the report. And the details of that, you probably know. We don't. And I think what we're more concerned about, for me, my sake, is the outcomes. What are you trying to achieve by this? And I do think that's what needs to be highlighted a bit. And I think we do need to get the KPIs into that sort of remit so that we can then see this report in the way that you wish us to interpret that to help you develop what you want to try and do. So that's just a purely observation overall. In terms of figures as well, and turnover of staff seems to be the thing you keep coming back to, that's what I've been listening to all morning. I noticed there's variation within the report. There's 10% in one place, 12% on the pie chart. Again, if those percentage points are so critical for you to be able to try and achieve your objectives, I do think there needs to be a bit more of an accurate element in terms of making sure that those figures are accurate. Do you see what I mean? Otherwise, what are we scrutinising when the report's happening? And then finally, I just wanted to say, for me, the funding's been mentioned, just over £1 million. No one else has mentioned money today, so apologies for that. But the whole of the health service relies on it, and so do all of us in terms of wages and everything else. My question would be, is that enough for now, and what about the future? You keep mentioning the future, or the funding and everything else. Is there enough funding for you to take on board everything that you're doing, which is fantastic work, star surveys, everything else like that, and actually develop what you're trying to do to improve safety, we've already mentioned, other things like this within the workforce that will make an even bigger difference to all those people employed there, for those people to provide services, which we all rely on. I'll shut up there. Thank you.
So just let me pick up a couple of those in advance of Mish coming in. So I think the answer to some of this, page 11 to page 43 is the annual report of the ICS on people and culture, which was really sort of background reading and arguably probably should have been an appendix rather than sort of the first bit you read. The actual presentation started at system level and then worked into the individual providers. Hence, the difference in numbers is you've got a system number and then you've got the individual providers' numbers. So Mish is just going to confirm that for everyone else's benefit, and then she'll answer your last question.
Thank you, Jeremy. You're doing my job for me, so thanks very much. Yeah, absolutely. That is the reason. And you might see if there was some figures in the annual report bit that they may slightly vary on the basis it was about the year that's gone past. So, but I understand that there's a lot of numbers and there's also a lot of jargon and lists. So would really welcome, and I've written it down here around the KPIs so that you can scrutinise that and absolutely accept that and take that forward. The money question is an interesting one, never with an easy answer, I don't think. I would suggest that we have to be much more efficient about the way that we do things. I don't think there is enough money for us to do everything we want to do. What we need to do is to focus in the areas that both from a clinical safety and quality perspective, as well as our surge and our demand, absolutely the highest risks and challenges for us. But for me, the workforce as a whole is our area of biggest risk. So we need to invest in that. We need to invest in new roles. We need to make sure that we have staff that are in the right place, being paid the right amount of money, doing the right things. And we need to try and retain people. And I know I keep saying that, but I think that we probably are going to be under even more financial pressure as the year and the years go on. I don't think there will be rafts of money coming in to support more and more training, education and development and more recruitment. Now, that's just my view, so this isn't a political view, it's my view based on my role in the NHS and social care. Having said that, though, I do think there's a lot of potential. I think that the fact that we are working together, we're all here together today, we are working in the most effective and efficient way. And we'll continue to improve. You know, Gemma talked about the 2 out of 5. For me, I think that that's a really good place to start, it's a realistic place to be. Bearing in mind the number of organisations we have in our county, the number of different providers, their priorities, and the fact that we are really cognisant of what we need to do differently to try and get the best care to our citizens. So I think there's potential, but I do think that we're going to be under significant pressure.
Keith?
Yeah, just an overview. For me, the document is more internal. So we're looking at it from an internal point of view. We're trying to understand what you're doing internally. I think if you can get the better message out there externally, and that will be about job retention and everything else, it will also give other people the idea of what you're trying to achieve within the health service. And that might well include extra funding. If you can get that message really, really well told out there, then that might well come forward. It's only just an observation, that's all. Thank you.
And a really helpful one, and if there's anything that colleagues in the room can do to support us with spreading our message, we'd be very, very grateful for that. And if there's any meetings or forums that you think it would be helpful for us to join, where you think there might be funding available, that we could think about where we recruit and how we train our workforce differently, then please let us know.
Thank you. I've got no other questions coming forward, so on that basis, I would just like to thank you, Mish and team, Gemma, Alex, Paul, Kay, Sophie, Lorna, for your involvement this morning. I think I'm just going to be a bit brave and see whether the committee support this. I think there's a huge amount of work and strands of activity that is being done across the system. It's certainly the most collaboration I've seen across this area. And you've also got some very disparate stakeholders and some who don't particularly want to go down the route of appraisals and other such things, and they're probably some of the people who need to do it most, without saying anything more than obvious. But I think we're beginning to see some of the benefits of working as a system, and that's coming through. And I think we probably want to encourage you on that journey, and particularly in terms of shining a light on the stats and the KPIs, because I think that's one of the ways of demonstrating success. And I think that's what we've seen this morning. And obviously, you've talked about flexible working and the importance of that. And the other thing I'd just pick up is maybe looking at those KPIs and how we can incorporate some of the questions that members have asked this morning, both in terms of employee engagement and you know, checking that the direction of travel is still the route that everyone's going on. Is committee happy with that as a sort of a summary in terms of where we've got to? There you go. And so thank you for your involvement, and maybe we'll see you again, you know, flexible timeline to do that, because I think there's some really important issues here, but maybe we'll drill down to a very specific area. And you were going to provide us with some additional information on international recruitment, incidents of violence, mapping of learning and development programs, and employee engagement. I think those were the key elements that we asked, or we promised to come back to us on. So on that basis, thank you. Those who are not involved in the rest, you're welcome to stay, you're welcome to go. Thank you for your involvement. And we will move on to item number 5, social care, Staffordshire social care workforce, and an update on that. Obviously, we've seen some of this journey already before. Welcome to the Cabinet Member and to Amy Duffy. And obviously, I'm sort of mindful that you've given us nice bits of strategy before. I'm sure everyone's got their strategy document and use it as a point of terms of reference. Amy, with you, 5 or 10 minutes possibly for introduction. If it's 5, that would be great. But I think Julia would like just to start.
Yes, thank you very much, Chairman. And in view of the time pressures, I will be very brief. As you say, the workforce strategy has already been presented to Scrutiny, and this report has 2 elements. One is an update from the Health and Care Overview and View Scrutiny workshop and the round table discussion that you held on the 14th of August. It was attended by adult social care providers, representing care homes, both residential and nursing, home care providers and supported living providers. And in addition to that, there was the input from 270 respondents of the local annual staff survey. I think it's fair to say that the majority of discussions and items identified very much reinforce those that were identified within the strategy. I would have been very disappointed had that not been the case, because the strategy was developed very much in conjunction with our NHS colleagues, and I think today has identified that we've all got the same key challenges and that actually that greater collaborative approach is going to bear and is bearing fruit. I think that's really important. The second element of the report goes into what we're doing in terms of the Social Care Academy, which is one of the key areas of work, and the report sets out the objectives of that academy. And obviously we welcome any questions and comments from Scrutiny, and now I'll hand over to Amy. Thank you.
Many thanks for the introduction, and just to note that Andrew Jeps is also online supporting the item today. So just in terms of picking up some of the key themes from the provider roundtable, in the appendix documents you'll see that I've pulled together the key points of discussion, and I've placed them under 3 key themes. So firstly, looking at around communication and engagement, just picking up on the numbers there that we just talked about. So we've talked about our staff survey, and we have noted already a positive improvement from conception of the strategy, where we had just over 20% of the workforce telling us that they were intending to leave within the next 2 years. When we revisited this at the point of strategy launch back in April, that's actually reduced to 14%. What we do recognise from the discussions that were hosted at the round table, we need to improve the uptake of that survey so it is more representative, and actually look at the various provider data returns and so forth that are coming into us locally and nationally, and ensuring that we can make better use of them to further support our workforce. What the discussions also highlighted was the need to expedite the work around multidisciplinary working. So some of our providers gave first-hand experience of not always feeling as a professional within their own right, respected by others. And given obviously the complexity and the level of care and support that's provided to our residents on a day-to-day basis, that was something ourselves and our ICS colleagues are looking to expedite in terms of that multidisciplinary working. Moving on to identity and equity, obviously one of the key things is that when we talk about adult social care providers, we have to remember that there are multiple different service types. So we touched on the attendees, residential with nursing care, residential care, supported living. What the data shows us is that each area, each service type has its own challenges. So our current challenge and our next phase of work is actually tailoring those actions in co-production and partnership with our providers to that specific cohort. So if we use example home care has very specific challenges around transport. Our workers' cars are their offices to get them from A to B. We need to look at the associated transport costs. Also, looking forward to apprenticeships and some of the items we're going to talk about when we talk about the Social Care Academy. Those coming new to care and of the younger cohort, actually getting a home care apprenticeship for that cohort of people can be very problematic. So actually it's about raising the profile that we touched on in the previous presentation, that apprenticeships are for all life courses of a person's career pathway. Big one, and I think it underpins the whole of the strategy, it's celebrating social care. So it's actually about shining a light on the work that our workforce does. And through that, we will also attract people within our sector. Finally, that takes us on to recruitment and retention. So it's promoting social care as an aspirational career, that you can be a care worker, that you can be a registered nurse, that there are career pathways internally. And we continue to hear feedback that we need to raise more awareness. And that links us into our value-based recruitment. And one of the actions that we picked up was increasing adult social care placements. So getting people to try different parts of social care, different roles and responsibilities, so they can too make an informed career choice. And finally, I'll just reflect on pay. It was discussed at the recent roundtable to note that it is a low-paid sector. And that will continue to provide us with a challenge to recruitment and retention overall. Just taking you forward now to the Adult Social Care Academy. So, the purpose of our academy is if we note the feedback from the adult social care reforms, it noted that a significant proportion of the workforce, and this is nationally, do not hold relevant qualifications. And then if we combine that with the skills for care feedback, that it indicates turnover would be reduced by 9% for care workers with 30 or more instances of training. We then combine that with our local feedback. So the local feedback from our workforce is there is probably lots of learning, training and development opportunities out there and funding to support us to access them, but we don't know where everything is and we can struggle for time to complete that research. And also that typically learning, training and development outside of items such as degrees and so forth are not typically celebrated. So building upon that, we have, following discussion with a cohort of partners, which is detailed in the paper, which does include our local colleges, universities and our independent training providers, we are introducing a social care academy. It is a very purposeful decision to make that a standalone academy, demonstrates the value, the investment and us trying to build that social care identity. It will have two primary cohorts. People already working within social care and people who are considering working within social care. It will not duplicate any of the current learning, training and development opportunities. It will seek to house them in one easy and accessible place with signposting. And in addition, we will look to deliver bespoke training based on that local intelligence and need. Through the establishment of a social care academy, we hope to come together as a single unified voice that will actually, as a collective voice, we will make better coordinated use of those local resources and actually act as a driver for change. Our intended impacts are we want to increase our recruitment, we want more effective retention, we want to improve the quality and the competency of our workforce, and we want to increase those opportunities for work-based learning. Thank you.
Brilliant, thank you. Charlotte.
Just a couple of points. I see that there's a 16% vacancy rate for nurses working in care homes. I appreciate that mostly NHS pay rates are higher, considerably higher than social care. Does that also mean that nurses working in the social care sector would be lower paid than nurses working in the NHS? Or maybe it's an issue around promotion prospects or whatever, to try and identify the reasons why nurses don't want to work in the care sector. And secondly, could you clarify, the Adult Social Care Academy talks about bespoke learning, training and development. Does that mean that the Social Care Academy is not providing nationally accredited qualifications? It's more related to filling gaps within the local market rather than providing more transferable national qualifications.
Amy, we're with you.
Thank you. So just in relation to your query in terms of nurses within care homes, what we understand from our cohort is that it does primarily relate to those terms and conditions. We do also understand there is a variance in terms of hourly rates of pay in on some occasions. What we would also say is, linking back to the discussions we've had throughout the course of the morning, it's not just about promoting a career in nursing, it is also about promoting there is a career in nursing within adult social care and selling the benefits, as the local intelligence that we are receiving is that social care nursing is not typically sold or not given the same focus and attention during a person's training and when considering their career opportunities. So it is an active piece of work we're trying to bring together. Moving on to your second question, we won't seek to duplicate, as I said earlier, in terms of any of the learning, training and development that's there, so be that local or national and that accredited. What we will do is that we will seek to identify where there are gaps or we do need something particularly local, perhaps because of the needs of our population. We are, as part of the academy, where it is not delivered by, as part of one of those national training or part of that accreditation, we are bringing together a local quality assurance. So it will look at things such as using accredited training providers, and we are looking to bring in ways that we demonstrate that it is quality assured. There is a piece of work nationally taking place under the adult social care reforms about building a care worker's passport so that any learning, training and development that they participate in moves with them as opposed to perhaps staying in the organisation should they depart. So we want to feed into those conversations and replicate that so a person will always be able to take that learning, training and development with them.
Sorry, can I just clarify on the issue of nurses' pay? I mean, clearly within the NHS, there's a very clear pathway to more senior roles. Are you saying that basically that doesn't exist within social care? I mean, it may well be that they've not had that exposure to the idea of working in social care, but the bottom line is nearly always going to be pay, because you know we've got many nurses going to food banks, and if they're not going to be paid so well in social care, then it's likely that they're not going to be in social care. I mean, 16% vacancy rate is pretty devastating when you're talking about an elderly population that absolutely requires that professional input. So I just clarify on the side of pay, because I can't see why a nurse would go into the social care if it meant that their career prospects were less bright, and their chance to climb up the pay ladder would be less significant.
Julia.
Chairman, I think in terms of within the nursing home sector, I think there are key elements. One is it isn't a sector. There are a series of providers, large and small, and obviously they have their own terms and conditions. You know, we as a commissioner of adult social care have increased rates as much as we possibly can. For home care providers, I think it's just over 9%. You know, we recognise the situation and don't shy away from that, but we do try to actually increase the rates as much as we can. But within that sector, unlike the NHS that work to national terms and conditions, they have independent pay review bodies. Whether you think that's the right way to go or not, that's another matter. But within nursing homes, as Councillor Atkins obviously realises, there are a whole range of providers who have their own terms and conditions. Some are very good at career progression within their own organisations. Some, possibly the smaller operators, it's a different case in point. I think one of the things that I'm very keen on, within healthcare, social care, we have the same problem. We've got increasing demand through an increased elderly population, advances in medical treatments, people are living longer but not necessarily in good health. We've got to do things differently, both within the NHS, and I now put my public health hat on. We are trying to encourage and educate people to live healthier lives, because that pays benefits in the future and will help, hopefully, to reduce the demand on both health and social care. We all have that personal responsibility, you know, to eat and drink and do what you want and expect somebody else to pick up the tab later on in life is no longer sustainable. And I have to say this because I think I'm an older generation. There is a point at which we have to admit we cannot expect the working younger generation to keep paying more and more, because that's the route we're going on. We have to do things differently. And one of the things that I would say in terms of nursing care within the care home sector, we may have to look at a slightly different model of supporting those nursing homes. It is an issue. I'm a great believer, if somebody is in a care home, that is their home. If we can actually help through our home care system to maintain people in their home, we perhaps can do a little bit more at how do we help to continue to support them in their care home rather than them having to transfer to a nursing home. There are some cases that are unavoidable. They need that intensive nursing home care. So I think we've got to challenge ourselves and challenge the whole sector. And that's where working with our NHS colleagues, it's helping us to actually say, is there a different way of providing this? But it isn't a one national system. So there are varying terms and conditions. But I think by raising the profile, raising the status, working with care providers, we can start to address some of these issues. But it's not easy, I'm the first to admit.
And I seem to recollect that in terms of customer base, very crudely, because obviously, you know, there's care homes, home care and nursing homes. It's about a third, and a third county council funded, a third NHS funded, and a third self-funders. So I think that may be just relevant to the discussion. Charlotte, did you want to come back on? Thank you. Janice.
Thank you very much, Chair. I'm tempted to ask if there's any medical professionals that need to tell me what my core body temperature should be. But for a tip, if you plug in your laptop and put it on your lap, there's a little bit of heat. So, you know, just a top tip there. I know. Just a couple of things for myself. I attended that round table, and I found it one of the most insightful meetings that I've been to in a fair while, shall we say, to the point that I actually emailed the chair afterwards to say how beneficial I thought it was, but also being able to appreciate those nuances between the care providers and the sectors in which they're operating in, and I think that's a big difference at the moment. But appreciate the efforts of what's being done to try and get that alignment. You mentioned a little bit earlier on about the travel fees, and I just wondered if there was something that you could elaborate on that, just to give us a bit more detail. So I think that's one of the key things that I've heard of in the past as being a reason as to why people found a disparity, potentially. And also, if there's any detail available on any pension offer as well, because sometimes that can be an attractive proposition in some cases. And then my next question is about the academy side of things. So I don't know if you want to just do that one first, and then I'll come back to the second one in a bit. Thank you.
So just in terms of the travel, so when we were shaping our strategy, we were talking to the home care provider market, and they reckon as a minimum, the average age of a care worker's car is at least 7 years old. So they have to pay, obviously, maintenance, upkeep and so forth. And whilst obviously a number of those items will be, they will be reimbursed for, it was just noted, obviously, that for home care workforce, transport is a bigger proportion of outspend for them. So in addition to the council supporting with the annual discretionary fee review process, of which obviously we can't specify how that money is subsequently aggregated, and obviously there is a HMRC mileage rate and so forth, what we've tried to do is working with organisations such as VivUp, which we've extended to our independent workforce, we are trying to increase the number of offers, benefits and discounts on there for car-related expenditure. So, for example, at the minute there is a particular supermarket within VivUp that is offering 5% off fuel. So we attempt to promote them. We've also got a petrol price app finder. In addition, we are considering utilising the market sustainability funding to actually support with some of the other related costs. So once again, looking at home care, it's a key requirement of any job, of a home care worker job, to be able to drive. We have to recognise for young people that driving is inexpensive. Learning to drive is very expensive. So it's understanding how we work with our workforce to perhaps help with some of those initiatives and those endeavours. Just in terms of pensions, coming back to the response to the previous question, because we have so many individual employers, I wouldn't be able to say to you what each of our individual employers do offer. It may be that a number will rely on the national offerings and so forth. So I think that once again is going to be really, really variable by providers.
Janice, do you want to come back or ask the academy question?
Yeah, so, but we're just on the pension side, I think it's one of those things that might be worthwhile having some more investigations into. And certainly, whilst the demographic might not be so attentive to pensions at this particular point, that actually it's one of the reasons why I think some people decide that they'd go to work for the public sector as opposed to private, potentially. So the academy question, basically, I think for me, it is about that value that we place on adult social carers. And I never underestimate the power of putting on a uniform and being part of a community that is giving something back, especially. In this particular case, I think it is filling that gap. You've mentioned quite explicitly there's no, or there's a significant attempt to avoid any duplication, which I think is appropriate. So as far as the offer is there, is that something that people will be able to access online, the practicality of it, fitting it in around any other duties, not only their caring professional role, but maybe other caring, that they have in their personal life as well. And also building that team, I think that community spirit. Thank you.
So I can confirm that the longer term vision for the Academy it will be a hybrid model. So it will offer both e-learning that can be completed on an individual basis, virtual learning, and then longer term we will move to in-person opportunities. That's obviously for the stuff that we are going to commission and deliver. Obviously we will also act as a booking, the ability to book for those courses that are delivered by all three of those mechanisms for our partners locally. So the longer term vision is that it will be hybrid. Just to pick up on one point that you made there about peer interaction, that actually comes through really, really strongly. And actually people say by attending a training course with other people that they may not actually have encountered, be that it's an ICS training course, so actually they're working with a clinician who before they would have never encountered, that actually is really, really beneficial. But also through the provision of the academy, we do want to build on those peer networks for people to be able to interact and engage with each other.
Thanks. Just as a follow-up, a couple of thoughts in terms of the academy. First thought is I like your sort of target metrics on this screen behind me. Maybe we could push you slightly to look at actually defining what those metrics look like in terms of SMART metrics. You know, really difficult when you're devising something new for the first time, but it does strike me that, you know, it is worth having those numbers and what you're looking to achieve, because actually then you know whether it's good or whether there's some additional tweaking to be done. And equally, sometimes if you set out to do something for one person, you set up in one way. If you're going to set it up to do 100 people, you do it in a different way. And maybe that would be a helpful thing to do. Second of all, in terms of scalability, it does strike me, I'm not aware of other counties and upper tier authorities in social care who are doing this. Maybe there is lots of them. But it does strike me that if it's going to be virtual, then actually there may be a mechanism of training more people in the industry and recovering some of that cost and making it cost neutral for Staffordshire residents. Thirdly, just on this, it strikes me that you'll have a personal relationship with those people being trained. And having an understanding of who they are, in my view, is quite helpful, because you can have a long-term dialogue with them about, you know, the industry and other training opportunities and other discussions and dialogues that you want to have that today you can't have because you don't know who those people are.
Thank you. I'll just come back to each one of those. So in terms of the metrics, they are broken down in the business case. So in terms of looking at improving our recruitment and retention, we'll continue to follow the theme of the strategy, and that will be looking at our skills for care data set. In terms of quality and competency, we will look at our CQC ratings. Obviously, that only impacts regulated care services, but we will have a baseline, and we'll also look at evaluation and feedback from the actual delivery of training. And then through increasing our work-based learnings, we'll use our national data sets around apprenticeships and so forth. And actually, as we devise some of the more sector-based work academies and so forth, we'll actually be able to capture how many people went through that particular programme and how many people successfully gained employment. Scalability and sustainability. We would hope through the provision of the academy, as I said, we would have a better utilisation of that funding. So, for example, adult education funding, can we actually streamline and target that? So we are hoping to look at that streamlining of our fundings alongside looking at the Market Sustainability Improvement Fund as noted in the paper. And in terms of the professional relationship, the personal relationship rather, our academy will be underpinned by a learning management system, which most academies are, and it will be through that we will be able to capture the who, the how and the what. So there will be, what we are aiming to build is quite a detailed log-on that would talk about Amy, that I work within home care, this is the current scale or position that I'm within, and these are my aspirations. So I hope we will be able to capture that information and move that forwards.
Thank you. Do we have anyone else on this item? No, on which case, Julia and Amy, thank you for sharing that with us. And I'll move on to item number 6 on page 87. The background, Julia, Amy, stay with us or leave as you want, up to you. The background on item 6 on the agenda is, I think, relatively simple, which is providing some assurance following the Countess of Chester Hospital, Lucy Letby trial, some assurance of the appropriate ways within the Staffordshire and Stoke-on-Trent ICS system for people to be able to speak out. So Tracy Shewan is going to lead us through this. So Tracy, we're with you.
Okay, thank you, Chair. And as you say, this report relates to a letter that we received just to remind us all in the NHS what our responsibilities are following the harrowing details and outcome of the Lucy Letby trial and case. So all NHS organisations, actually since the Francis report, should have had freedom to speak up guardians in place and arrangements for staff to speak up. So we've been asked to check all those out, and there is a self-assessment tool we can use and have used, and each organisation has done that, that's related from the National Guardian's Office. So you can go through, but that really is more, it's like a tick box. I think the important thing here to say is we can have all these in place, and as you can see, it's listed there. You know, staff should have easy information to be able to speak up. Leaders have it's timely to remind leaders you must listen to your staff, to your patients, to your carers when they're speaking up. So the mechanisms are in place in each of our organisations and is in place with the ICB, and I am the Integrated Care Board Executive Lead. I'm particularly not the Guardian because we've decided that's not appropriate, and you'll see that in each organisation that the Guardians come from the workforce. And it's really important also that they do have access to executive leads and to the chief executives, and that happens in all NHS organisations across Staffordshire and Stoke-on-Trent. I think, like I say, the details of what we've been asked to review are there. We have each organisation undertaken that review. We meet as a network, so there's a Freedom to Speak Up Guardians network across Staffordshire and Stoke-on-Trent, where the Guardians can support each other and discuss issues, and this letter itself was discussed at the last network meeting. So really just to conclude is that it is Freedom to Speak Up Month, so there's a lot of action going on across all of our organisations promoting Speak Up, and that's during the night time as well as the daytime, because it is really particularly noted that sometimes people who work nights mainly do not have the same opportunity or access as others. And it's focused very much on what are the barriers and removing barriers for people to speak up. So just to conclude, it's really important that we have these processes in place, but even more important that the culture fits with the processes, because that's really what gets the change rather than just an exercise in this is what we've got in place.
Thank you, Tracy. Janice.
Just a quick one. Thank you very much for those reassurances. And even more so with your reference to who was the appropriate person. As far as the time frames for this, we've had the check that's been done this time round. Is there a period that's been identified to how frequently that is going to take place to make sure that it is still the case?
I think that's what I'm saying. It's within the culture. So certainly it's the self-assessment, and I've ensured that, you know, we lead on that. So we report to our people, Culture and Inclusion Committee, Freedom to Speak Up, which is the themes and trends. In the Integrated Care Board, it's a bit more difficult because we've only got 300 staff, so you know you don't get that sort of level of detail coming through. But in the bigger organisations, you know, they report them through their governance. So definitely an annual check. But again, it's also sometimes from the committees. They may wish to say, well, where are you on this report? You know, because it does ask you questions about, are they well resourced? Do you need more resource for your guardians? You know, are they on the correct pay? How many are you getting through? So I think you have to see it as a dynamic thing, because if you're getting a lot of freedom to speak up issues, what's going on? You need to dig below it, which is what I'm trying to say about the culture. You need to dig below it rather than just do the assessment itself. But I'd say it's recommended to be an annual thing, but I think things if you see the questions in it, you'd be asking them on a continual basis.
Anything further? Phil, we're with you.
Thank you, Chair. I think that the thing that stuns me most about this report is that it hasn't existed forever. And I think that's what surprises me, because I think most organisations will happily say that they allow freedom of speech, that they allow whistleblowers and all sorts of stuff. So I can't see us I can't see us we're in a really new place, because shouldn't this have existed anyway? So that I haven't finished. Sorry, I know you're reaching for the button, and so I'm surprised this didn't exist anyway. Secondly, I agree with I forgot the lady's name. Sorry, but thank you, Tracy. But it is down to culture. You know, I've worked for a number of organisations over the years, and it's all down to culture as to whether that will be accepted or not. Because it's also down, as well as culture, to the individual line manager as to whether he encourages that, or or whether it's acceptable. We've sort of done this in a few pages report, and I think it's really difficult. Because it comes down to personalities. It also comes down to, on the opposite sense, where people will use a whistleblower policy to do something wrong to somebody else. So it's not easy. It's really difficult, this, Mr. Chairman. And I admire you for having a go. It's not a criticism. So my take on this is where are the review stages? Where are we looking at it and sort of looking at it as comparison as to whether we're getting reports? So that would be the simplest one. And who's overseeing the complete thing to see whether this is genuinely working? So what concerns me is we do this because we've had an horrific thing happen in Cheshire. It was Cheshire, wasn't it? We've had an horrific thing happen in Cheshire. So there's this, let's all charge to do something. But the reality is whether we're still doing that in 12 months' time after it's all gone. My suggestion, if I may, Mr. Chairman, to you is we look at this again. We look at this again in 6 or 12 months. I don't think this is one we can look at once, because it has long-term implications and may not cause problems again for 2 to 3 years, Mr. Chairman. I think somewhere there may have been a question in there.
I caught 3 at least.
Thank you. And I think it's important to note that there is an independent inquiry into what happened at the Countess of Chester. So it's important that we recognise that and actually all the details, because there'll be some nuances and there'll be all sorts of evidence that will come out of that inquiry, which will actually tell us what actually went on and who listened, who spoke up, who didn't. So I'm not ever going to prejudge any of that. That will carry on. I'm trying to think. So this actually came about. So it's the National Guardian's Office that oversee all this, and our guardians are trained by the National Guardian's Office. So there's a whole, we have a guardian, and I always remember her name, it's double-barreled Chidgley Clark, who is a nurse, who is the guardian across all of the NHS organisations. So there is an oversight organisation that does this, and it came about following the Francis inquiry in 2015, because it was felt then that sometimes in NHS and where NHS services are provided, it's been difficult for people to speak up. So yes, these arrangements have already been in place, but I think as you picked up, Councillor, it is about the culture. And I think we'll hear more as we go through the independent inquiry on actually what was going on with the culture within the organisation, because to some degree, if you listen to the news, people did speak up. It's what happens after then. So I take all your points that you say, and no doubt this committee will be bringing things back as the inquiry progresses.
Phil, anything further? You raised a question for committee, I think, which was, did we want to come and see some of the results of the policy either in 6 months or in a year's time? I think that's a really useful question. And do you have any suggestions, or do you have any?
No, but I would like to see. I would like to see this. I would like to see this come back genuinely. Whether it's 6 weeks, probably. If you take into account the inquiry, I would guess 12 months. But I still would like to see this come back, Mr. Chairman.
Some organisations have annual reports, don't they? And it does feel to me like this should be sort of an annual thing that we just pick up and find an assurance on from the overseeing body, which is the ICS. So the other question you asked, which is who's overseeing the overseers, and the ICS is the body who does that. So I think it would make sense in conjunction with Zach, we'll try and diarise something into the future so that we do pick it up just on an annual basis. If committee are in agreement with that? Yep. Okay. I've got a couple of questions, Tracy, if I may, please. First of all, I note on page 3 at the bottom, it talks about cultural barriers and to speaking up. Bernard, if he was here, would want me to ask the question about what happens where English is not the first language. It may be sort of the last language. So how easy have you made that for people whose mother tongue isn't English? And second of all, in terms of these self-assessment tools, what are the individual system partners, what does the results of the self-assessment tell us so far?
Okay, thank you, Chair. And in terms of freedom to speak up, issues around cultural barriers, that's our focus this month, this year's focus. But all the arrangements that we have in place that we use for our patient population are there for use for all of these as well. So there's all sorts of interpreters services, there's access for those who are, hard of hearing, there's all sorts of those access that we use for our patient care is actually access to people, it's accessible for people to speak up with. So that's across the piece. In terms of what's it telling us so far, I know what mine's telling me so far. So the network, I know that UH&M have completed theirs and we discussed that at the network. And what it's sort of saying is we've all got the arrangements in place. What we need to do is ensure, well, what's happening after. Are things reporting back quick enough? Because sometimes that's the issue for people when it comes to speak up. Because it's quite anonymous. So if I meet with someone, I won't know who it is. They will talk to me about what the issues are. It's how do we put them in place to ensure we close the circle. Some of these things, point taken earlier on, why do people raise these issues? So that's the bit really, is how we look at it across the system now of what are the particular issues in each organisation. And we did have the discussion, should we share speaking up guardians, should people have access to that? And that's something that we will continue to look at as a system. But as I say, we have the things in place. It's actually what comes after that that's important.
Thank you, and no doubt that'll be part of the onward conversation we just discussed. Philip, good morning. Good afternoon.
I think culture change was mentioned in paragraph 10b, little 3, Roman italic 3. Highlights that. The Francis report, I'm one of the unfortunate few who read it all, lived it, mentioned that the culture was there when he did the report in 2015, looking back at 2003. The culture was there then. So the culture's not changed in probably 25, 30 years, as I read the Lucy Letby inquiry will come out with. So I think we've somehow, NHS leaders and boards must ensure proper implementation and oversight. Now, I don't quite know, Chairman, what our role is in that, because one of the things I noticed with the Stafford thing was that it was very easy. Scrutiny was quite new, and there was loads of inspections and everything else in the health service. And if we're not careful, we'll just end up as somebody else to blame. And so I question what our role actually is. Who is it who has to see that the NHS leaders and boards must ensure proper implementation and oversight? That's the question I'd ask. Because you don't want to end up swearing to say the truth and everything but the truth and everything in front of an inquiry. Just a word of advice as one who was there.
Thank you. And I think Tracy's going to, as our expert witness and subject matter expert, is going to answer this for us. No pressure there, then.
No, and I think you've already mentioned it, is to ensure that, you know, your scrutiny, oversight and scrutiny is to ensure that we do have the systems in place and that, you know, we reporting on that. The CQC actually has overall responsibility for assuring speaking up arrangements. So when CQCs do their inspection, they will be looking into those sort of things as well. So there will be questions you want to ask just to assure yourself that that has been done, that we have the right procedures in place. It's just a question to ask yourselves that we have. But like you say, CQC is primarily the body that will look at assuring speaking up's in place, because actually CQC is an area you can go to raise any concerns you have about any CQC registered provider.
Thank you, Tracy. And it's a really good point, Philip, because, you know, as Tracy indicates, you know, our job is to make sure there's a process and a system and that it's working appropriately, which is why it's on the agenda today, funny enough. First opportunity post-Letby. And I'll just pose a more general question, which is, I wonder how many other scrutiny committees across the country have actually done the same thing, because your point is exactly right. If you're not careful and don't ask the right questions, then we'll have missed the role that we have. Any other questions on this one? No, I'm seeing no further indications. Tracy, thank you for bringing that to us. If there is something you think we should be aware of that comes out of the self-assessments, please can you approach us appropriately? Otherwise, we'll come back to this in due course. Otherwise, thank you for your involvement this morning and for the work that you and your teams do. Let me move on to item number 7, which is the district and borough scrutiny meetings. I'm just going to make one point, which is the detail in these reports feels really light. It's interesting to know you had a meeting, but frankly, if we don't know what happened in the meeting, what's the point? You might as well just not bother, you know, using the paperwork to say you had a meeting. I'm not really interested in the fact you had a meeting. I'm more interested in what were you doing and what were the outcomes and what can other people learn in this room from the meetings that you've had. Does anyone want to give any verbal updates? Val?
There you go. I've got it now. Thank you. That's great. It's lovely to see you all. Okay. Right. Well, the Wellbeing Select Committee at South Staffordshire District Council has met twice, 6th of June and the 10th of October. So I'll give you the report for the 10th of October. We've now got Councillor Kath Perry as the county representative, which we're very pleased about, and we won't go into that. So the first item on the agenda, we had it was a discussion on community matters. South Staffordshire Community Safety Partnership Action Plan 2023 to 26. I will give, do you want me to send this over to you afterwards? No problem. Okay, the update on the progress by South Staffordshire Council, Maggie Quinn, she's the Community Wellbeing and Partnership Officer, and Staffordshire Police, and that was Darren Platt, the Deputy Commander for South Staffordshire Local Policing Team. The outcomes of the discussions were to reduce all recorded crime by 2%, to reduce vehicle crime by 2%, to increase the number of repeat victims of domestic abuse accessing services by 20%, to reduce serious violence, including violence against women and girls, by 2%, reduce antisocial behaviour by 3%, and to maintain the high level of feeling of safety during the day, 88%, and improve the feel of safety after dark, which was 67%. There was a very, very long debate on all of this. I'm very conscious, Jill, that you mentioned earlier on that the word was what, 2% of what maybe. So in future with my reports, I will improve on that. Forgive me, just new at the game here. The second item on our agenda was the report of the Environmental Health and Licensing Officer, Jenny Rhodes. And basically, air quality has improved in England over the recent decades. However, it continues to be an environmental risk to public health with children, the elderly and the already vulnerable most affected. So as a local authority, South Staffordshire Council, we monitor air quality within the district under the local air quality management regime, which has been in place for many years. South Staffordshire's previous reviews and assessments have proved sufficient evidence to be satisfied that the council's area is only likely to see exceedances of the NO2 annual mean objective. This was further confirmed in April 2019 when the council commissioned air quality consultants to carry out a review of air quality across the district and scrutinise a development consent order application for a strategic rail freight interchange hub known as the West Midlands Interchange, which I'm sure you're all aware of. This work resulted in the consultants being satisfied that the district's air quality is good. It flagged up a couple of concerns along the A449 in Penkridge and Huntingdon, where additional air quality monitoring tubes were put out. So South Staffordshire District Council proposed to employ air quality consultants early next year to again model the air quality across the district with the latest information and data, and then develop a measurement and improvement plan, if required, focused on the new air quality strategy. That also, we had a very, very long debate. That's it, Chair. The only other thing I'd like to mention, you are aware of it, that on the 11th of October we had an online meeting with regard to cross-border issues for South Staffordshire residents, particularly Kinver, a semi-rural area right at the bottom of the long peninsula of Staffordshire, which hopefully members might be aware of. It's a bit of a dogleg for us, sandwiched between the West Midlands to the east, Shropshire to the west and Worcestershire to the south. In addition, transport infrastructure tends to run into then West Midlands rather than north into Staffordshire. So there are problems there, which we have discussed the other day, in South Staff's residents often finding navigating the complexities of the NHS problematic. And this can be particularly difficult for our residents simply due to the location and NHS borders, but that's now an ongoing discussion with yourself and members. I do appreciate your input the other day. Thank you. I hope that I've covered what I need to, members. Thank you. Okay.
No one to ask any questions. I'll move on to Phil on that basis.
Yeah, thank you, Chair. I represent the County Council, or this committee, on the Cannock health. Unfortunately, they've managed to hit my holidays beautifully twice. So I've had 2 weeks holidays, and on that occasion, that's when they called a meeting, which is slightly frustrating because I'm a meticulous attender of meetings, and I do like to attend every one. I have written a couple of times to officers and to yourself to say, can we have a sub on? They'll only have 3 to 4 meetings a year, so I'm already a huge disappointment to them. So is it possible that we could look at it to put subs on? I know it's not written there, but maybe we could look at that. Because with so few meetings, and I know it's a little bit unfortunate, if it was going to miss the odd one, that's fine. But I've got another holiday booked later on in the year, so the way their track record is, they're just aiming for that, aren't they, really, just to keep me away? I mean that flippantly. But I would like us to look at whether we could put subs on, because I'm sure having the County Council there present would be useful.
Thank you, Phil Holliday-Hewitt. I think you make a really good point in terms of the code of practice between districts and boroughs and the county. Next time we do a revision, I'm going to suggest we take that on board. I would also suggest that maybe the vice chairs or the chair might be happy to sub for any holiday that members have. Not to go on holiday instead of them, obviously. But seriously, it's sometimes useful just to go and see how other committees work at a district and borough level. So maybe, if members do have that problem, then happy to offer that as an alternative. I keep meaning to go to more of them, but I go to Stafford quite regularly, but that's for other reasons. Thank you, Phil. Anne.
Thank you, Chairman. I just wanted to mention that, Stafford Borough Council met on the 5th of September, and I don't understand why there's no report on here about it, because the main item on the agenda was discussing freedom leisure. and the performance report of Stafford Borough. I just wanted to mention that because I can't understand why there's nothing on there. I will take that up with the officers. Thank you.
And I think that was the reason for just sort of mentioning how sparse these words were. And maybe Zach can take that up with the relevant officers as a comment from committee. Are we happy with that, reflecting that back as a comment from committee? Yeah. Okay, does anyone else have anything else in terms of that item on the agenda? I've got two. I did see you earlier, and I didn't know whether you were indicating or not, Leona. So we're with you, and then we'll come to David.
Hi, I represent Lichfield District Council. So we had meetings in September and also in the early parts of summer as well. So health was mentioned in quite a few items, and thank you for answering my queries on the email. So main items mentioned were basically the Samuel Johnson midwifery unit, which is temporary closed. We've increased, so from our meeting and what our members and their residents have raised is with increasing housing in Lichfield districts, and also many young families are moving into our districts. There is a push for the reopening of the Samuel Johnson midwifery unit due to more young families coming in as well. So hopefully, in future, if we can see that be opened, that would be very useful for our increasing of the young population as well. But also with the increasing population in general, especially with new housing in the districts, that people see it quite hard to have access to GPs or medical advice in general. So if there are any, people have mentioned maybe leisure centres or different community centres where they can get easier access to medical advice, that would be very useful as well. And we also would like to invite if there could be a county councillor present in one of our meetings for updates. That would be very good as well. Thank you.
Thank you, Leona. Just on two of those points, in terms of forward agenda, the maternity is on the November meeting, which will cover the freestanding birthing units, which is what you're talking about, Samuel Johnson and Stafford both being closed currently, temporarily closed. And I think we might have Heather Johnson possibly to join us on that. Yep. And in terms of primary care, the estates debate, I think, is a really important debate within that, and that's scheduled for the January meeting on January the 29th. So both are on all of our agendas, so I think we probably share some of your pain and hope that we might see some steps forward. David.
It was just to follow on to Councillor Hewitt from Cannock Chase. So both of you are very welcome to our committee. There's nothing in this from Cannock Chase really, so I'm going to chase it up as well. We're looking at electable standards of housing, and we've got a lot of social housing in Cannock Chase. So we're looking at housing again, and we're also starting to look at sustainability, but that's a massive thing, so we've got to talk tonight from some of the officers. I totally take your point around the updates and information. So if not the officers, I'll update you around what we're doing around that work. But you're more than welcome to come. 5th of December is the next one, so I don't know when. 5th of December. There we go. Spot on. I was just thinking that. They got this one right.
So did I hear from Phil Holliday Hewitt that he won't be on holiday? So just trying to regain control of this discussion. Thank you for that confirmation. Just in terms of public health, we're quietly looking at the forward agenda going forwards, because we did a lot of work last year on sort of the wider determinants of health, of which housing would be relatively high up that list, alongside employment. Obviously the regulator for social housing and the housing ombudsman are playing a much greater role in housing, and that will have some impact on districts and boroughs as the housing authority. But maybe we might just pencil something into early next year to have another discussion on that with some of the public health professionals in that area. Okay, so does that neatly take us... Sorry, David, did you want to come back? No, okay. Just you seem to reach for a button. So just moving us on to item 8 of the agenda, which is the forward programme. So members will have seen that we've got an additional meeting on the 13th, which is dedicated to West Midlands Ambulance Service, 13th of November, which is when we will meet next. That is a 2 o'clock start, just to confuse people. And the meeting that we've put in addition to the agenda here, which we've sent you electronic invites for, is for Monday the 20th of November, the following week, which is to discuss the air quality at Wally's Quarry and to look at the health impacts of that. Please note that it is at Newcastle Borough Council offices, and it is also a 12:30 start. So if you're not confused enough as it is, then you will be really confused. And then we're meeting thereafter in terms of the formal agenda on the 27th of November. So apologies, we seem to have a lot of meetings all in one go, but just the nature of the work we're having to respond to. Any further questions? Anything that should be added to the work programme? This is your work programme. Janice.
Chair, if I could just give a quick update on the Women's Health Group.
Please.
We had one of the callers online earlier on, Dr. Lorna Clarkson, who's been identified as the representative in ICB for women and women's strategy. And it was an absolute revelation when we had our first meeting, in the fact that there's already a piece of work that had been commissioned between Staffordshire and Stoke-on-Trent. And remarkably, the contents of that particular report were very much aligned to what the working group had identified, which in some quarters we could be bold and say great minds think alike. On this particular part, being able to identify those issues specifically in Staffordshire has been absolutely, in terms of the time that it saved, has been instrumental in our next meeting on this Wednesday, being able to provide some focus onto what we want to do next in narrowing down what was an originally very long list into a much shorter list that we can give some good attention to. Thank you, Chair.
Thank you, and thank you for the work that you're doing on that. Really appreciate that. And maybe you'll just keep us up to date when you want something on the agenda as a formal item, even if it's just an interim sort of progress report, because we can certainly do that. Is there anything to report from any of the other working groups?
Chairman, just on the social care meetings, we've got a lot of them scheduled. In terms of the report that will come forward, that making sure that the County Council is doing its right bit in terms of the programme. So there's a lot of work to come there. So there's meetings that have been scheduled, but so far they've been constructive.
Thank you, really helpful. Any other updates on working groups? We will add that to the agenda so that we'll put an interim agenda item so that we cover that at all opportunities going forwards. Sorry, Val.
Yes, it was just a very quick one, Chair, to Janice. I'm sorry, I can't make that online meeting on Wednesday morning, but I actually run a community group. It's 9 till 12 on Wednesday mornings. It's sorry, I can't pull out of it, but I am particularly interested in this. Okay, thank you, Janice. Thank you. Thank you, Chair.
And if need be, maybe record the meeting if everyone's happy, and then you've got an opportunity to watch it back at another stage, maybe. Not quite the same, but, maybe an opportunity. Thank you. I think we can call stumps. It's 1:45. Thank you for your involvement this morning. Useful discussion and safe journey. Have a good afternoon.